You might trick me once, I won't let you trick me twice. Freedom to us has always been a trick. Freedom to you has always been whoever landed on your dick. Seen it in you one too many times. Said you might trick me once, won't let you trick me twice. No, might trick me once, I won't let you trick me twice. Might trick me once, I won't let you trick me twice. No, might trick me once, I won't let you trick me twice. No, won't let you trick me twice. Those days are old and overdone, and it's only 'cause I'm not with you that you make me number one. Though I may love you, it hurts me deep inside. And now you no longer have to hide. I used to be down with the late night hit. Started getting heavy when I really wasn't ready. Used my past to get my mind, so I fell for your lines like all the time. Thought you were the shit to be playing around. Call the police, there's a mad girl in town. Could get even here without a sound. It's not how I wanna get down, yeah. Might trick me once, I won't let you trick me twice. Might trick me once, I won't let you trick me twice. No, might trick me once, I won't let you trick me twice. No, I won't let you trick me twice. No, I won't let you trick me twice. Well, I pay my dues for all that I've done. Showed you that I loved you more than once. There's nothing left there to decide. Trick me, I won't let you trick me twice. You might trick me once, I won't let you trick me twice. You might trick me once, no, I won't let you trick me twice. No, you might trick me once, no, I won't let you trick me twice. Peace.
Ting drinking is very bad. Yo, I got a fake ID though. Yeah. 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 Two-step with me. Two-step with me. One. Then comes the two to the three to the four. Everybody drunk out. Baby girl ass jiggle like she want more. Like she a groupie and I ain't even no tour. Maybe cause she heard that I rhyme hardcore. Or maybe cause she heard that I buy out the stores. Bottom of the ninth and the nigga got the score. If not, I gotta move on to the next whore. Here comes the three to the two to the one. Homeboy tripping, he don't know I got the gun. When they come to pop and we do shit for fun. You ain't got one nigga, you better run. Now I'm in the back getting hit from my huns. Why she going down, I'm bragging on what I done. She smoking my blunt, saying she ain't having fun. Bitch, give it back, now you don't get none. Everybody in this bitch get tipped. Yes, bitch. 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 Two, then comes the three to the four to the five. Now I'm looking at shorty right in the eyes. Couple seconds pass, now I'm looking at the thighs. Why she telling me how much she hate a guy? Said she got a kid, but she got her tubes high. And you 21, girl, that's so right. I went there for shake, coming with them fries. They're so, baby, can I get them supersized? Here comes the four to the three to the two. She started feeling on my Johnson right out the blue. And you super thick, so I'm thinking that's cool. But instead of one life, I need two. Her eyes that big when she glanced at my shoes. Expression on the face like she ain't got a clue. Then she told me she don't run with the crew. You know how I do, but I guess I gotta do. Everybody in this bitch get tipped. Yes, bitch. Everybody in this bitch get tipped. Yes, bitch. Everybody in this bitch get tipped. to the 6. Self-explanatory, I ain't gotta say I'm rich. Just single man, I ain't tryna get hitched. Nigga wasted on me, man, son of a bitch. Brushed it off, now I'm back to getting lit. Goose and orange juice, man, it's some good-ish. Homeboy tripping cause I'm staring at his chick. Now he on the sideline staring at my click. There comes the 5 to the 4 to the 3. Hands in the earth, if you catch drunk, it's me. Club on the set, Quan put out them trees. Dude, I don't care, I'm a PM. Everybody in this bitch get tips. Yes, bitch. Everybody in this bitch get tips. Yes, bitch. Everybody in this bitch get tips. Yes, bitch. Everybody in this bitch get tips. Yes, bitch.
This is for scientists and those who believe in the potential of science. It starts with curiosity, surprise in the pattern, an obstacle that comes.
Whatever you want, I got it, Bobby. Don't hesitate, holla at me. What I'm looking for, simple you see. Love is more than sexuality. When I'm with you, don't wanna leave. Need you just like air that I breathe. But when I'm not with you, I'm missing nothing. Got a lot inside, need to release. You fulfill my every desire.
Africa is said to take your breath away.
I'll come back. There is no way I'm leaving. Do my Afro you're the only one I'm needing. Let I go, oh yeah. 'Cause there is no way I'm leaving. There is no way you can get away. Need your love every day. Medicine can't cure the way that I feel. What I need is my inner pill. Being without you, making me ill, stressing me out. I need to chill. Something that's
smells could make someone ill. Taking the bus to university, there's always someone that just smoked or puts on way too much perfume. I'm studying to become a biomedical scientist. I love learning new things, and I've always wanted to understand what is wrong with me so I could know how you possibly could fix it. And I think that
This went on and it got more and more frequent. And would give me an oral steroid. And then a few months later, it would happen again. And he finally got to the point that he said, "You're not getting better. We need you on this all the time so you function."
The oral steroids, they have saved my life many times. They have terrible side effects, really awful. They would give me a bloated face, bloated stomach.
My severe asthma attack is that I don't react the way you're after that, like postponed room.
People would come and they that see
Africa is said to take your breath away. The beauty, the splendor, the vastness, the sunsets and the sunrises. To many in Africa, it's not the beauty that takes their breath away. Puma, to breathe. Puma, the initiative. In Swahili, the word for breathe is pumua. Life is measured in breaths. From the first breath we take to our last. And quality of life is all the breaths in between. AstraZeneca is improving quality of life day by day, patient by patient. The AstraZeneca Africa Pumua Initiative is an innovative program committed to redefining asthma care in Africa. Why Africa? The statistics are simply breathtaking. The disease is real and affecting more and more people daily. There are more than 40 million people living with asthma in Africa, and every single breath they take counts. Asthma patients don't need to hold their breath any longer. As building on a 50-year heritage in respiratory care and their portfolio of medication to treat asthma, AstraZeneca's ambition is to redefine asthma care in Africa by supporting fundamental changes in the management of asthma. Through public and private partnerships, this initiative will strengthen local health systems and centers. Supported by invaluable local knowledge and expertise, the aim is to build an infrastructure for asthma patients with nebulization machines, nebulization stations, spirometers, and peak flow meter donations. By supporting healthcare worker capacity building across the pediatric and adult asthma patient journey, we aim to ensure effective diagnosis and enhanced referral systems. Facilitating equitable access to high-quality AstraZeneca respiratory medicines in the public and private sector is aligned with AstraZeneca's sustainability goals. Through AstraZeneca's partnership with various governments, healthcare professionals, and societies, the Africa Pumua Initiative aims to improve pediatric and adult asthma management across public and private sectors. We aim to positively shape treatment guidelines and protocols for chronic asthma aligned to the GINA guidelines. This initiative forms part of AstraZeneca's sustainability commitment to deliver improved accessibility, acceptability, affordability, and availability of quality care in Africa. At AstraZeneca, we are unwavering in our commitment to improve care for asthma patients throughout Africa. People living with asthma deserve the best care and to be able to live normal and healthy lives. Inhale for a better future.
This is for scientists and those who believe in the potential of science. It starts with curiosity, a surprise in the pattern, an obstacle that can't be explained. Step by step by step, they challenge, explore, and unlock the unknown, fueled by imagination, alone and with others, repeating an experiment 1,000 times to have the chance to get it right. Once, but for forever. Making brave choices, choosing to push the boundaries, and choosing again and again to be led by science. and those who believe in the potential of science. It starts with curiosity, a surprise in the pattern, an obstacle that can't be explained. Step by step by step, they challenge, explore, and unlock the unknown, fueled by imagination, alone and with others, repeating an experiment 1,000 times to have the chance to get it right, once, but for forever. Making brave choices, choosing to push the boundaries, and choosing again and again to be led by science in everyday decisions, everyday interactions, no matter where they are. Because putting science at the center of everything is the best way to understand and transform disease, the best way to change people's lives. This is why we believe in what science can do.
Africa is said to take your breath away. The beauty, the splendor, the vastness, the sunsets and the sunrises. To many in Africa, it's not the beauty that takes their breath away. Puma, to breathe. Puma, the initiative. In Swahili, the word for breathe is pumua. Life is measured in breaths. From the first breath we take to our last. And quality of life is all the breaths in between. AstraZeneca is improving quality of life day by day, patient by patient. The AstraZeneca Africa Pumua Initiative is an innovative program committed to redefining asthma care in Africa. Why Africa? The statistics are simply breathtaking. The disease is real and affecting more and more people daily. There are more than 40 million people living with asthma in Africa, and every single breath they take counts. Asthma patients don't need to hold their breath any longer. As building on a 50-year heritage in respiratory care and their portfolio of medication to treat asthma, AstraZeneca's ambition is to redefine asthma care in Africa by supporting fundamental changes in the management of asthma. Through public and private partnerships, this initiative will strengthen local health systems and centers. Supported by invaluable local knowledge and expertise, the aim is to build an infrastructure for asthma patients with nebulization machines, nebulization stations, spirometers, and peak flow meter donations. By supporting healthcare worker capacity building across the pediatric and adult asthma patient journey, we aim to ensure effective diagnosis and enhanced referral systems. Facilitating equitable access to high-quality AstraZeneca respiratory medicines in the public and private sector is aligned with AstraZeneca's sustainability goals. Through AstraZeneca's partnership with various governments, healthcare professionals, and societies, the Africa Pumua Initiative aims to improve pediatric and
36 million asthma exacerbations globally per year. And there's also an estimated 116 million emergency room visits per year due to asthma. In the US alone, we have greater than 10 million exacerbations per year, resulting in more than 1.8 million visits to emergency departments, and about 170,000 hospitalizations and more than 4,000 deaths, unfortunately. These attacks are both physically threatening and emotionally significant for many patients and can be fatal. And also there's a hefty economic and social burden, as we all know. With 5 decades of experience, we are an established leader in respiratory care. That's asthma and COPD. We are committed to transforming care for some of the most debilitating and chronic respiratory diseases. But for the purpose of this meeting, we'll be talking about asthma. In order to ensure equitable access to all asthma patients, AstraZeneca rolled out the African Puma initiative in Ghana and other African countries, where we basically reduced the cost or the price of our Symbicort so that every asthma patient can access it on the National Health Insurance. We also supported asthma management by installing hundreds of nebulization stations across the country. The purpose of today's meeting is to learn more about these asthma conditions from our expert panel so that we can enhance the care we give to our patients. Let's engage in productive discussions, foster collaborations, and inspire each other to push the boundaries of asthma management and so that our patients will get good outcomes. So without further ado, let's get started. Thank you. Achu.
Thank you very much, Mabel, for that brief introduction for today's event. My name is Amos Achu, and I'm also with AstraZeneca. Just like any other event where there's a need for a chair for a meeting, today is no exception. Briefly, I'll be introducing the chair for this occasion or this meeting. Today, for the Ghana National Asthma Forum, we have the chairperson to be in the person of Dr. Jane Efriye-Mensah. She's a fellow of the West Africa College and Ghana College of Physicians. She's currently the head of respiratory clinic and pulmonology training at the Kolebu Teaching Hospital. She also co-supervises the medical ICU at the Internal Medical Department and a part-time lecturer with the University of Ghana Medical School. She's also a clinical fellow in respiratory medicine from the University of Leicester, UK. Currently, she's the vice president of the Ghana Thoracic Society. So today we have a very well-abled chair
But in no time, the side effects began to settle. And unfortunately, respiratory physicians had to share their patients with the endocrinologists because the asthma patients became cushions in inverted commas. Now, in the 1990s, another wonderful thing happened with asthma management. We had the inhaled corticosteroids. This was great, very good at preventing recurrence of symptoms, reducing hospitalizations and urgent care visits. It was a great thing and a great news to be welcomed. Now, the reason I say asthma management is on a top speed. Now, we are not talking only about that. There's a new level that talks about the use of targeted treatment for specific asthma patients. Here, the medications are looking at interleukins. So we have the anti-interleukin 5, interleukin 6, and interleukin 13, and it keeps going. And there has even been the anti-IgE therapy way before the interleukins came on board. The speed is very great. And where are we now with respect to Ghana? Well, we are still struggling with adopting inhaled corticosteroids for all our patients. The world is way ahead. But we don't think that we have indeed, our standing now is anything to be happy about. Should we therefore be tired of hearing asthma, talks on asthma, how we manage asthma? No, I don't think so. We shouldn't be tired at all until all our patients, as much as we can, are on at least inhaled corticosteroids, whilst we try to catch up with where asthma is going now. And this is exactly what we are doing here this afternoon. We want to emphasize the need for accurate asthma management. We don't want to be behind anymore. And for this reason, we have gathered here, and I'm very happy that we will leave here with a lot of information. We'll change our mindsets with asthma management, and it will be a wonderful discussion after the presentations. Without wasting much time, I would like to set the ball rolling for the next phase of the program. Amos, can you please take over? Thank you. No problem. Okay. All right. Okay. All right. Yes, please. Thank you so much for your patience. So I would like to go ahead and introduce the first speaker for this meeting. And the first speaker is no other person than Dr. Samuel Kwabena Asumani. He is a senior resident at the Department of Respiratory in Kolebu, Department of Medicine. He's well versed when it comes to asthma. He's been a speaker on asthma for many years now, and he has the answers to every question that you would like to ask. Without any further comment, let's welcome Dr. Asumani to the podium to give us the first presentation. Thank you.
Thank you very much for that arduous task she has given me. Right, so we want to take some short time to talk about asthma management, and especially with emphasis on inhaled corticosteroids. You know, as she said, whilst the world is way ahead of us, unfortunately, some of our patients are still not, up to even moderate treatment with regards to inhaled corticosteroid. And so we'll look at the treatment or the current management of asthma, and then do this within a very short time. I think at the end of the day, the most important part, or probably the second most important part, will also be to ask and share opinions and questions that will be addressed. Okay. Can we start? Right. Asthma is very important, and I believe that no matter your practice, you come across asthma from child health all the way to geriatrics. So it's very important, as the chair said, we shouldn't get tired of it, because wherever you are, you come across it in one way or the other. And to have at least some idea at managing it at the primary care level will be very, very important. Right. Thank you very much. So asthma, we know that even the local folks sometimes are able to get it right. What makes it important in our sphere is that a lot of things that behave like that may not be asthma. So with that, we just have to know right. So of course, that is a disclaimer. So please, everything I share here is purely from the facts available and duly referenced, and is not because of the organizers of this program, and therefore they are not liable for the accuracy of what I say here. Right. Can we move on? Is it moving? Right. So this is no news. We know now that asthma is not the same in everybody. So we say it's a heterogeneous disease. One of the most important chronic disorders of the airway. And its symptoms, as I said, the local folks may themselves be able to tell the symptoms. Now, the most common symptoms, as we know, cough, chest tightness, wheezing, and then breathlessness. And as we are also aware, a number of things behave like that. When this complex of symptoms occur together, it means it's very likely that the person may be having asthma, especially if this occur in a setting of reversible airway obstruction. So if you're able to prove that there's a reversible or a variable airway obstruction, whilst we still have these symptoms together, then the person will say to be having asthma. Right. So despite the fact that sometimes the local folks get it wrong, we also get underdiagnosis of this condition. And oftentimes, we also get overdiagnosis, because sometimes everything that wheezes, we tend to think is asthma. But that may not be the case. Right. And it's because sometimes the basic thing that we need to make the diagnosis, apart from clinical, is not to catch up. We should be thinking about how to at least make some confirmatory or diagnostic tests available at these primary care levels. Right. Now, I mentioned 4 cardinal symptoms, but we know that almost every respiratory condition can present with cough, dyspnea, breathlessness, chest tightness. Now, when you have these symptoms occurring in certain pattern, then the frequency, or let's say the probability, becomes high that it could be asthma. Especially, for instance, when all other things are eliminated. Nothing else can explain it. And then especially, so these symptoms tend to happen and worsen from time to time, day to day, and from season to season, tends to worsen during the night. And usually, you will not have significant chest discomfort or chest pain. When these things happen in the backdrop of chest pain, then you may be looking at some other things. So the features that make it probable. Let us also know that you may not necessarily have a family history, but somebody who has significant family history may also have that as a probability, especially when the symptoms that I mentioned happen in somebody who has significant family history. That could also make it a possibility. And then one, they can tell you that when they come into contact with certain things that we know now as triggers, the symptoms are worsened or are precipitated, then probably we are dealing with asthma. However, there are other things that we also have to look at that will make you question whether your diagnosis of asthma is correct. If somebody had these symptoms and they're having copious production of sputum, all right, you have to be thinking about, am I dealing with asthma or I'm dealing with something else? Because something like bronchiectasis could also behave like that. If somebody has that symptoms I mentioned, significant dysphonia, you may be having to make sure that you have excluded other differential diagnosis. Chest pain. Usually asthma doesn't cause chest pain. Sometimes what they describe as chest discomfort, it's like a band, you know, especially in the lower ribs, where they feel as if something is restricting them, more like, tightness rather than pain. But if somebody has these symptoms together and complaints of chest pain, then probably we'll have to be looking at that. Again, if somebody came with that symptom and has significant past history or even current history of smoking, you have to be thinking about a possible other diagnosis. Right. Now, I won't bother you with this, but what we want to say is that all these symptoms that we are talking about, the driver is inflammation, chronic inflammation. And he mentioned a number of mediators, interleukins, interleukin 3, interleukin 4, 5, interleukin, 13, interleukin 33. All these things drive it, especially in the people who have the so-called T2 type of asthma, where it's usually pro-inflammatory. But what does this inflammation do? It tends to make the airway hyper-responsive. So people who have asthma, their airway is hyper-responsive to very no-cause things that other people can tolerate. And so they become very sensitive to things that commonly may not induce or exacerbate the 4 main cardinal symptoms that I mentioned. Now, when somebody presented with a combination of that symptom that I mentioned, you have to ask yourself, can something else explain it? All right, if that's something else can explain it, you work your way out, and then you either confirm or you rule it out. But if nothing can explain it, and you think asthma is possible, especially when you have examined and you think asthma is possible, then you have to try and see whether there's evidence of variable airflow limitation. And that is where we suggest that at least some confirmatory tests should be done. Spirometry nowadays have become not too over the top. It should be available. But if spirometry is not available, then we use peak flow. It's better than none, but spirometry is really preferred. When you do that and we're able to show that there is variable airflow limitation, together with the symptoms, especially when you are sure that no other condition is explaining this symptom, then of course you can say that the person has asthma. But note that somebody may have all these symptoms, and at the time that you are doing the test, the spirometry may be normal. So the fact that spirometry may be normal does not mean that the person may not have asthma. If you are using peak flow, then you can't just use 1 point in time kind of peak flow. You need about a week or two where the person will be taught to take their own peak flow, having been taught how to blow it maximally morning, evening, for at least, preferably 2 weeks, but at least a week. And then brings the chart to you. You are going to calculate the percentage variability, where you look at the difference between the morning and evening, and then also you concentrate on your asthma. Now, the situation that this person's first time coming is in acute situation, and you make sure that there's nothing else to explain the acute presentation of dyspnea, cough, wheezing, chest tightness, and you think that is acute exacerbation of asthma, and you have excluded all the differential diagnosis, you treat as such, and later you can then confirm. Right, so the goal previous last, he said, when the salbutamol came, the emphasis was on symptom relief. But we know that now the aim of treating asthma is not just about symptoms, it's also about symptom, and then also trying to control for risk of exacerbation, risk of side effect, and risk of getting the person into an irreversible type of airway obstruction. So that is our aim. And we know now that asthma is not just a bronchoconstrictive disorder. We know, as she said, that inflammation plays a significant role. How do we do it? We assess the patient, and assessment means that you have to make sure the diagnosis is correct, because asthma can behave like any other respiratory tract disorder. Confirm and make sure the diagnosis is correct. And when the diagnosis is correct, you have to teach the person about it, and also know that asthma may not exist alone. Sometimes we call something comorbidities, and commonly sinus diseases, upper airway disorders, and other things. Sometimes it can even exist with COPD and other things like that. So you need to ask questions and try with the patient together to find out whether this symptoms is exacerbated by the comorbidities, or the comorbidities themselves could be the diagnosis rather than your suspicion of the asthma. And when you make that, you treat those comorbidities, and of course, if the diagnosis being confirmed as asthma, you treat. And definitely you need to review. Once you start, you don't just put the patient on treatment, the person goes and that's it. You need to keep reviewing. Right, now she mentioned certain paradigms in asthma. When it began in the 70s, we were interested in relieving symptoms, bronchoconstriction. As time went on, we knew that asthma was not just only bronchoconstrictive disorder, but inflammation was significant. And now we know, for instance, until 2015, we felt that, oh, somebody who had mild asthma could just do with salbutamol or PRN. And that was wrong. And that was why enough evidence became clear that even at the so-called mild asthma, we needed to control the inflammation because of what we are calling remodeling, airway remodeling, because the inflammation gives to structural changes within the airway that turns mild asthma into becoming a very severe type of asthma. So currently in the 2000s, we're only not thinking about just bronchoconstriction. As we say, our emphasis is controlling symptoms and also trying to deal with the risk of exacerbation. Therefore, we are also very much interested in controlling the inflammation and trying to prevent as much as possible the airway remodeling that tends to change the phenotype into a very severe form. In the 70s, there's no room for just a single agent short-acting beta-agonist use in relieving just asthma. Now, because as patients enjoy it, they get relief and the device is handy, they tend to overuse that. But we as practitioners must encourage them that there's no room now for just, relieving symptoms without controlling the underlying inflammation. All right, and so now emphasis is not only on that, because evidence suggests that if you use only the SABA, the exacerbation will continue. The inflammation is unabated and the airway is undergoing remodeling. So somebody who used to get few symptoms, now with time, the same environment hasn't changed, the same exposure to the same allergens, now will have a very severe phenotype. So there's no room for just a short-acting. Overuse of this also have been associated with cardiovascular incidents. Risk of MI, risk of heart disease, and so on. And even risk of death have been people who use more than 2 canisters a week and so on, they are at risk of death. Right, so we need to control the inflammation to prevent remodeling. And evidence suggests that even what we call the mildest asthma, they have evidence of remodeling. So if you, for instance, biopsied the airways of asthmatics, all the spectrum from mild to severe, you realize that there will be subepithelial fibrosis at all levels, even though the thickness is marked in severe asthma. But even in mild asthma, you realize that there's going to be some evidence of remodeling. So what happens is that with time, the airway is undergoing structural changes. And that would change the phenotype. Somebody who probably might be called mild intermittent now would develop a very severe asthma. Right, so means that if you are treating and getting relief by your symptoms from SABA or short-acting beta-agonists without dealing with the inflammation, then you are converting a mild phenotype to a severe one. All right, okay. So now, for instance, because of that knowledge that asthma is driven by chronic inflammation, the phenotype that we will call mild, where people get less than, say, 2 symptoms of asthma in less than 2 days, or let's say 2 days or more, but not every day, where, according to Gina's steps, maybe step 1 and 2, we know that inhaled corticosteroid in the form of the formoterol-based preparations, so ICS formoterol-based preparations have been found to be very useful both at controlling the inflammation and also the symptoms. And this is the way the world is going. There's enough evidence to support that, they're using, traditionally we use, even when the ICS became available, let ICS, inhaled corticosteroids, then you use short-acting beta-agonists as and when needed. But now it's been found out that in a single agent ICS formoterol-based preparations, you can also relieve the inflammation and then also control it in the long term. So you can use it for both acute and then also for maintenance. And enough evidence support this. Now, one of those that informed this current guideline is the so-called Sigma 1 and 2. In that particular study, they used people who will qualify as mild asthma, step 1 and 2 of the GINA steps, and they were either given SABA as and when needed, or formoterol ICS as and when needed, and then also they give them budesonide as a maintenance. And what was the evidence? It showed that those who were using the ICS formoterol, they were not using every day. They ended up using almost about 30% of the cumulative steroid dose. But in the long run, the same effect in terms of exacerbation and then also in terms of even severe breakthrough attacks. So what it meant was that those who were even using everyday maintenance were not superior to those who were using the ICS formoterol as and when they had symptoms. Previously, we were saying that everybody needed to be on every day, but that kind of study suggests that if you have a mild attack or mild chronic asthma, you do not need to use your agent every day. You could use it when you have symptoms. And the evidence is clear that it wasn't, in fact, it wasn't superior. The maintenance people were not superior. Where's my pointer? Right. Is it here? But it's not visible. Okay, sorry. All right. So the one in the red, okay, the top one is the short-acting beta agonist, and then this one is the as and when needed, and then also we have the budesonide maintenance. And you realize that they are almost the same line. So it means that the everyday maintenance therapy was not superior to the ones that were using it as and when. And probably it's a good news because we know that those who fall in the category of mild asthma almost constitute about 70% of our patients, especially our primary care. So it means that they can use it as and when. You know, maintenance is a problem. Compliance is always a difficult one. So if I can only use my device only when I have symptoms, then probably it will improve compliance. And so that evidence is quite reassuring. And similarly, maintenance was not daily use of ICS compared to as and when needed ICS formoterol was not superior to the as and when, okay, when it comes to exacerbation or probability of having exacerbation. So it means that you can be sure that if your patient will use it when they are symptomatic, they are not going to be worse off. Right. Good. And when they used it like that, there was about 65% reduction in the emergency visits and even hospitalization. They were not using every day, but the ICS formoterol people was about 65% reduction. All right, and compared to those who were using maintenance every day, they were using the ICS, and compared to those who were using as and when needed, about 37% reduction in the emergency visits and hospitalization. So it means that for compliance, the people who you think will fall in the category of mild would definitely benefit when they are using it as and when necessary. Now look at that, and this other, the Sigma 1 and 2 and other such, evidence have informed the current guideline, and you realize that now at all the stages, okay, at all the stages is ICS formoterol, which is preferred at all the stages. The ICS formoterol is very flexible, unlike the other ICS, LABA preparation, because the formoterol base, even though it's long-acting, but it has fast onset of action. So when you use it, within 2 minutes, you begin to act, just like salbutamol or any of those short-acting would have begun. So now that is the preferred. And those who are in the category of mild definitely can use it even as and when needed, just to ensure that they are safe and also they are not worse off. All right. Now, those of us in primary care, maybe we'll be seeing most of this up to about step 4, step 3. All right. You could still use the same device. And in step 3, they can use maintenance dose. And when they are getting exacerbation, they use 1 PRN. So they can have morning dose, fixed dose, morning, evening, and then 1 PRN. And knowing that the maximum allowable dose is about 72 microgram, it means that you have a lot of flexibility when you are using the ICS formoterol-based preparations. And definitely around this time, you probably at primary care should be referring, because here difficult to control. The others are also there. You can use ICS plus SABAS and when needed, but you know compliance is an issue, and you have to use multiple devices and so on. Right, so this is exactly what we are saying. You use the same inhaler, all right, and then as needed. At step 3, same inhaler, you take 1 twice a day, and then you use 1 as needed. And then in step 4, the same, but you have to increase the dose. And definitely step 5 will have to be in expert hand. Right. Okay, so you cannot use that single device ICS, LABA, unless the LABA is a formoterol preparation. And so in this regard, we only have ICS formoterol approved for being used as maintenance and what? Reliever. You can't use any other ICS plus LABA as both maintenance and what? And reliever. But those that have formoterol, because as I said, it has a fast onset of action, can be used both as reliever and then for maintenance. And it's been approved and being used in many guidelines now. So it's not a new thing. Good. Right. So the available ones, we have the budesonide formoterol, and in Ghana it's marketed as Symbicort. I think what is on our market is 164.5, and I think there was the 80 stroke, I think 4.5. And then elsewhere we have beclomethasone formoterol. So these ones can be used for both maintenance and relief of symptoms in the same device. Right. Note that when you start and you get your patient controlled, when you start, it doesn't mean that your patient stays on the same dose. It's something you can titrate. When they are maintained on a particular dose without symptoms for about 3 months, you can begin to step down. And when you step down, you review them within a short time to see whether the symptoms have rebounded. Otherwise, sometimes we see that somebody has been started, and where they were started 2 years ago, that's where they are stuck, and symptoms are not controlled. You can always titrate up or down, and there's a room for stepping down. It doesn't mean that once you are stepped up, you remain there. You can calm down when symptoms have improved. And however, when you want to step down, you need to do it at the right time. For instance, with the person is within a period where exacerbation is going to be a risk. Let's say we are approaching a change in weather, maybe harmattan, rainy season, or the person has now become pregnant, all right, and you want to step down, that will not be appropriate. You have to step down at a time that this patient will not be at risk. Right. So, oh, sorry about that. I think I'm left with just about 1 slide or so. Good. So, it's not everyone that will be so easy to manage, even though you are using the right drugs. Sometimes you realize that the diagnosis is correct, the right drugs being used, the technique is okay, yet the patient is not improving. You may have to think about referral. Some people will have to be referred. This person has had any evidence or history of a severe life-threatening asthma at the primary care level. It would be good to push this patient to a specialist. If the diagnosis is not clear, you are not certain whether the diagnosis is asthma or something else, then it would be good to let this patient move on so that it could be confirmed. Right. So I think we'll end here and then we'll answer the rest of the questions later. Thank you very much.
All right, so thank you very much, Dr. Asmani, for giving us this, convincing us about the need for inhaled corticosteroid in asthma management. Now, the key messages we take from here is that there is no place for short-acting beta agonists alone in the management of asthma in primary care. I'm sure we have that message. I still see referrals of patients coming in with only SABA as their management, and this had been going on for years. So we want to emphasize this message: no place for SABA alone. And presumably, our mild asthma patients can go on to get airway remodeling. Another important reason to think about inhaled corticosteroid in every asthma patient. If we fail to do that, that can push them on to another asthma phenotype, and that can be very severe. Now, at any point, we still have to think about classifying our patients with asthma with respect to their severity. If you know that, then it will guide the dose of inhaled corticosteroid therapy that you need, because there's definitely a group that may have to use it as and when needed. Thank you very much, Dr. Asmani. And we'll move on quickly to the next presenter. And this is a seasoned pediatrician who works at a 37 military hospital. And he heads the pediatric department in this great hospital. Now, he is a member of the Pediatric Society of Ghana, a bona fide one, of course. He is a great resource to asthma education and to Ghana Thoracic Society, that's GTS. He co-founded the new guidelines that is very soon to be outdone again, the GTS asthma guidelines. And I can't sit down without saying that he attended St. Augustine's College. And in fact, this college supersedes the medical school and all other training that he had. Thank you, Dr. Emmanuel Pabi.
Thank you, my boss and chair. And that is very true. If you didn't mention St. Augustine's College, I'm sure I wouldn't have gotten up. It's part and parcel of me. All right, thank you very much. So most of my work has been done by my colleague, Dr. Asmani. So thank you very much, Dr. Asmani, for the wonderful presentation. My role here today is to tell us about the role of inhaled corticosteroids in the management of acute asthma exacerbation, especially in the pediatric emergency setting. And I'm sure most of this will also apply in other settings as well. So, I'm making this presentation on my own behalf as a professional, and AstraZeneca makes no representation or assumes no responsibility for the accuracy of information that I am providing. Everything is on me. So AstraZeneca, be rest assured. This will be the outline of my presentation. I'll talk about what is acute asthma, and then pathophysiology has been done for me already. The role of ICS has also been done in a lot of ways, and so I'll just share a few of my experience with you as well, and then later on we'll take your contributions. So when we say acute asthma, what do we mean by acute asthma? We say asthma, this has been done for me, so I'll just move on. But let me go back and then I've highlighted the heterogeneity of the disease and then the chronic inflammation. These are things that should not be lost on any doctor who will ever attend to any patient he or she thinks has asthma. That not all asthmas are the same. They are very, very, they present differently. So make sure you know your patient so that you know how best to manage the patient. Never forget that the main problem is chronic airway inflammation, which you need to manage. Now, what is acute asthma? It's a progressive increase in the symptoms that the patient will present. That is the cough, wheeze, shortness of breath, or the tightness in the chest, which does not respond to the patient's usual rescue medications. Because before the patient presents to you, the patient is a known asthmatic. He would have used his usual rescue medications. And if he gets better, I can bet you, he will not come to you. So once he comes to you, it means he has used his rescue medications. It's not getting better, and that is why he has come to you. Or the symptoms are even getting worse. And so it's a progressive increase in the symptoms. That's what we describe as an acute asthma. Most asthmas, before they are diagnosed, it will be preceded by an exacerbation. So the exacerbations that precedes most of the diagnoses that we make. Without it, it will be very difficult to diagnose asthma because they won't even come to you in the first place before you diagnose them. And acute asthma can be classified as being mild, moderate, severe, acute severe, and then near fatal. I put the status into brackets. Usually we used to say status, but it's now referred to as acute severe asthma. So these are some of the guidelines that you can use to help you classify the exacerbation or the acute asthma that is presenting before you. So once you have one in any of the severe categories, then you classify the patient in that category. So you don't have to wait to have all the parameters there before you put the patient in the category. So once you have one, so if the patient comes to you and the patient is cynosed, it's a life-threatening asthma. If the SpO2 is below 80, it's life-threatening. Once you get one of them in the severe case, manage it as such. You better do that before you become sorry. Now, in my pediatric asthma clinic, what do we see? We see roughly 30 to 40 cases in a week at the clinic. The female-male ratio is 3:2, and the average age of attendance is 7 years. And for children, I know the peak is between 5 to 9 years, so I'm not surprised that the average age at the clinic is 7 years. And at the pediatric emergency, we see 2 to about 5 cases of asthma exacerbation in a day. Sometimes, depending on the environment and what is happening, you can have so many of them coming at the clinic or at the emergency clinic. This is some data at the clinic attendance. You can see the numbers rising up. The last one was 2021. That was a half year. We were almost like the previous year up there. I need to update these figures for you next time. So the prevalence of asthma, we all know, is going up, and in children also, the numbers are going up and up and up. Pathophysiology, like my colleague said, for children, of course, the reason why the peak incidence is between 5 to 9 years is that when you are born, even though you may be predisposed to asthma, you have to be exposed to the triggers. And then the process will start slowly until such a time that it becomes severe for you to now start expressing the symptoms of the attack. And by that time, you should know that inflammation had gone on for some time before they will even come to you with the first exacerbation. And usually, because other conditions can also present like that, it's difficult to make the diagnosis on the first presentation, unless you have very wonderful history and then your clinical examination support that. So inflammation goes on and on and on before they come to you. So what are the initial management in an acute exacerbation? We know our oxygen therapy, if it's available, you should always start it. And then our inhaled short-acting beta-2 agonists, salbutamol and albuterol, which we are all very familiar with. And then apatropium bromide, then corticosteroids, the inhaled corticosteroids, or the systemic. Most of us are used to the systemic, giving the systemic, and not the inhaled corticosteroids. And I have to let you know that I am an ambassador of using inhaled corticosteroids, because since we started using inhaled corticosteroids as part of the acute management of acute asthma in our pediatric emergency, the number of cases that ends up at the ICU has reduced significantly over the last 6-7 years. And so it is very, very important that you start early. A lot of guidelines say maybe start after an hour if the patient is not getting better. My point is, why do you have to wait when you can start right from the beginning? What do you have to lose? Like the chairperson said, we are way behind. Why do we always have to wait when the thing has even passed and now there are new things coming? Then we are now going back to, we've passed it. We should, every patient you diagnose have asthma will have to be on steroid or inhaled corticosteroids to make sure that this patient is managed and managed well. What are we afraid of? Is it a side effect? The doses that we give when we are giving inhaled corticosteroids is so small that the systemic side effects is basically negligible. If anything at all, is a local maybe side effect, the airway. And once you go through the precautions of rinsing your mouth and all that, you are most likely not going to have those symptoms at all. So please, if you diagnose anybody with asthma, make sure the person is on inhaled corticosteroids. The management of an acute exacerbation is not only knowing that you have to give inhaled corticosteroid, give salbutamol, give apatropium, give oxygen, and then you go and sleep. No, you need to reassess. So you nebulize, what we call back-to-back nebulizations. You nebulize, as soon as you finish, you continue. Others say you nebulize and then repeat after 20 minutes, and then after another 20 minutes. So within 1 hour, at least nebulize 3 times. And then, depending on the response, you can then stagger either maybe hourly or 2 hourly or 3 hourly or 4 hourly until your patient becomes better to probably go home. But I say back to back. You finish first one, as soon as you finish, you reassess, and then you do it again. The principle of management, my emphasis here is reversal of the inflammatory cascade. And it is so important because, as has been said previously, if you do not manage the inflammation, then this patient will keep on having the symptoms, and then the airway remodeling will continue. I don't want my adult physicians to suffer more, so I want to be sure that at least my children are managed well, so the airway doesn't, because if the airway becomes remodeled, this patient is going to have the asthma for the rest of his or her life, because the airway is already permanently remodeled. So if we manage them well, say catch them young, and they will never be yours forever, isn't it? So let's manage them well, right from the beginning, and most of them would outgrow their asthma and will have a very quality life in adulthood. So what is the role of corticosteroids? Inhaled corticosteroids, they have a role because of the hallmark of what? Inflammation in this heterogeneous disease. Now, bronchoconstriction that the patient will usually present with, it is not only because of the smooth muscle constriction, it's because of the inflammation. So any management that only targets the bronchoconstriction or the symptoms is not adequate, or it's actually not recommended that you use only the short-acting beta-2 agonist. You need to manage the inflammation as well. Several guidelines advocate for the use of the inhaled corticosteroids, both in mild and persistent or severe or the uncontrolled asthma. Low-dose inhaled corticosteroids has a place both in the acute exacerbations and also as a preventer or in the long-term management. So it's not only in the preventive phase that you do, but even in the acute phase, you are supposed to use the low-dose corticosteroids. And this prevents the structural changes that result in the chronic inflammation and then airway remodeling. I mentioned this already. In my experience, at my emergency, we normally do a combination of this therapy. And I must say that you don't have to wait till you have all these 3. Whatever you have, you start. But if you have, when they come in with acute exacerbation, please add the inhaled corticosteroids to it, and you are likely you'll get a better response. Why Is it important? It is important because, I remember in medical school, they said the steroids, when you give steroids, it has to enter the cell, enter the nucleus, go and cause transcription, and produce proteins and what have you. So the effect takes hours or days, isn't it? What I normally say is that when somebody comes with maybe an urticaria, we give hydrocortisone, isn't it? And once you give the hydrocortisone, what happens? Within seconds or minutes, you see relief of the symptoms. So it means that it doesn't really, it's not true that it has to take 1 hour or 2 or 3 days before you see the effect. So the effect is rapid. Within seconds to minutes, you see the effect happening. So it is very true that inhaled corticosteroids actually works within the shortest possible time. And it is through the non-genomic pathway or mechanism of action. The genomic pathway is what will enter the cytoplasm, the nucleus, to go and cause the transcription and all that. But the non-genomic pathway, which acts on the membrane of the cells, is very rapid in action. And so this has been said, Gina, step 1, advocate for low dose inhaled corticosteroids. Whenever SABA is used, anytime the patient uses SABA, the patient definitely will need inhaled corticosteroids. The Egyptian Society advocated for the use of budesonide nebulization if there's no improvement after 3 nebulizations. But like I said, why would you want to wait when you know very well that this works? ICS can also be used at home, and for patients who can and are able to use it at home, you can actually teach them to be able to. I know a lot of adults who are on daily inhaled corticosteroids, and they will nebulize themselves with the corticosteroids before they leave home, and they are very fine. So for your patients who can, please empower them to be able to do that. ICS synergizes with SABA, and it does so by promoting the synthesis of the beta-2 receptors. So once you give the ICS, the synthesis of beta-2 receptors are enhanced, and therefore when you give your SABA also, it also works better. So the two work together to reduce the inflammation and bronchoconstriction. Nebulized budesonide also effectively has been shown to decrease the airway inflammation by rapidly decreasing the expired nitric oxide levels within 6 hours from the airway. And this has also been shown that when you do that, it also increases the peak flow rate as well. Budesonide combined with tebutalin also quickly and effectively relieves acute asthma attacks. And this was found in about 76 children with an exacerbation who were randomly divided into groups, for one to receive the inhaled corticosteroid, that budesonide suspension and tebutalin sulfate, and then others receiving intravenous corticosteroids with theophylline. And when these two groups were compared, they realized that those who received the budesonide nebulizations had rapid relief of their symptoms. High-dose nebulized budesonide, which was also added, when added to the standard of care, also reduces what? The hospital length of stay. So patient comes to you, normally you give your salbutamol, maybe you give your oral prednisolone, or maybe your IV hydrocodone or whatever. When you add the inhaled or nebulized budesonide, it reduces your length of stay in the hospital further. And this research showed that total hospital length of stay was significantly shorter in the Symbicort rescue group compared to those with the placebo. And after 2 days, 60% of the patients who were given Symbicort rescue were discharged home, compared to 24% of those who were on placebo, on top of the standard of care that we normally give. Early intervention with budesonide has also been shown to protect lung function decline in asthma patients. So once you diagnose them and you start early, the rate of progression or the rate of worsening of their lung function is significantly reduced as well. Because if you don't start early, then there will be progressive reduction in their lung function over time because of the chronic inflammation that keeps happening. So you start early, you reduce exacerbations, you reduce the decline in the lung function, and your patient will be better. So it has also been found out that people with African descent have some genetic markers that is associated with low lung function and frequent exacerbations. And so just giving the salbutamol or beta-2 agonist doesn't really help us that much. But giving the corticosteroids has been shown to also improve our lung function and also reduce the decline in our lung function as well. I'm sure we know this. Steroids suppresses inflammation, it inhibits the cytokine effect and its effect, and prevents morbidity and mortality among asthma patients. Regular use of low-dose inhaled steroids has been associated with a decrease in the risk of death among asthma patients. The side effects, oropharyngeal infection, and then for systemic absorption to occur, you have to give more than 800 microgram, and the systemic effect also becomes more pronounced when you have a lifetime doses of more than 2,000 grams, that is having cataract and what have you. And most of these steroids we are giving in micrograms. And so by the time you hardly get here. So start early so you don't have to give high doses. Because if you don't start early and the airway becomes remodeled, then you need higher doses to be able to control the asthma. So once you diagnose, start. So in conclusion, budesonide nebulization in asthma exacerbation has been shown to be effective and also improves asthma symptom relief and also reduces hospital length of stay. High doses of the inhaled corticosteroids stimulate the rapid non-genomic actions. So within seconds to minutes, you begin to have the effect. Budesonide induces vasoconstriction in the airways, which in effect also reduces the inflammation. Inflammation, a lot of blood flow into the area, and so once you do vasoconstriction, you reduce the inflammatory mediators that will come into the inflamed area, reduce swelling and what have you. So it also plays a key role. So don't use salbutamol alone if it is possible. Don't use it alone. However, if you don't have the others, and that is the only one that you have, please go ahead and use it. Thank you very much. These are my references.
Thank you very much, Dr. Pavi. It's getting heated up. Now, that's the pediatrician for you, isn't it? They are always obsessed with the word early. So he keeps using the word start early because their patients are always early. They are early age. Indeed, what we take from this is that SABA should not be used alone. Again, now we see that SABA usage in children, I don't know if it's only me, but it's quite high. The mothers prefer that. It must be on them all the time. Maybe because we also stress this so much. And I find children, hyperactive asthma children, because they keep using it, and the children are very active and they don't understand why. Because that is all they've been using and giving the children. We want to change this narrative. Now, we've also learned that SABA alone will generate tolerance at the receptor level in the airway mucosa. Combining this with an inhaled corticosteroid indeed is an effective synergy. And we get it working well, good response to the inhaled corticosteroid, and even when you have to use your short-acting beta agonist. Now, the role of nebulized salbutamol in acute asthma management has also been really emphasized, and we've had studies to the effect to show that this equally works and works very well. Great, thank you, Dr. Pabi. So we move on to our next presenter, and this is another great resource to asthma education in Ghana. He is a senior specialist, family physician, and indeed he's interested in respiratory diseases and cardiovascular diseases as well. He is the medical director at Finney Hospital and Fertility Center, which I'm very much not happy about because he left us in Kolibu. He is a great resource to Ghana Thoracic Society. Indeed, he actually coordinated the development of the Ghana Thoracic Society asthma guidelines. Now, he has a number of publications. He's also a proud part-time lecturer at the Department of Dietetics. What are you teaching them? But indeed, he's a good lecturer, and I've had some of his students always mention his name. Now, I think that this is NSMQ. Who can give me a guess of where our next presenter? Now, they don't want to talk about anything graduate. No, forget about the medical school. Who can let me know where the next presenter attended school? Yes. Oh, no. That one is my half school. Presec is my half school. So our next presenter indeed was in the school, in Fansipim School. Let's welcome Dr. Steele Dadzi.
Thank you very much, my boss. When your boss introduces you a certain way, it makes you tremble. So thank you so much. And thanks to the organizers for the privilege of having me do this presentation. So the topic is GINA 2024 updates and correct inhaler technique. So what is GINA? GINA stands for the Global Initiative for Asthma. It's the most authoritative institution on asthma management. So they pull together available evidence into a globally authoritative guidelines. They like not to call it guidelines, but rather recommendations. But that's the resource most of us fall on to manage asthma. So I'll talk about the recent updates. And I have to say that after my bosses have talked, I really have very little to talk about because what they presented is actually what is most current in the GINA recommendation. So probably my task will mostly be with the inhaler technique. So this is a disclaimer similar to what has been presented. So what will I talk about? I'll give highlights of the updates and then focus on diagnosis and management. And then we'll go into the techniques of use of the inhaler devices on the Ghanaian market. Right, let me say that I'm sure many of you know that we also have our guidelines. That is the guidelines on asthma management by the Ghana Thoracic Society, which was launched last year. And there is very little difference between the GINA 2024 and our guidelines, actually. So let me say that the highlights of GINA 2024 actually squares very well with that of the GTS guidelines. The definition has been talked about, but the little bit I want to say in this regard is the fact that asthma is a heterogeneous disease. When we say it's a heterogeneous disease, it simply means that it's underlined by different pathologies. Some are allergic, some are not allergic. The relevance of that is that especially for the allergic cohort, they don't only have asthma, they also have associated comorbidities like allergic conjunctivitis, allergic rhinitis, atopic eczema, and food allergies. Quite often, we ignore these conditions. So you have a patient who has been on asthma treatment for a long time, but nobody has paid attention to the fact that he or she also has allergic conjunctivitis, allergic rhinitis, and they may never have received treatment for it. Prior to coming here, I saw a 13-year-old boy who has had asthma since early childhood, and he's been on treatment. In fact, I'm sure Dr. Asmani will not be happy with the treatment the child has been on, neither Dr. Pabi, because that child has been on salbutamol all his life until recently that somebody introduced him to inhaled corticosteroids. But I asked the mother, does he also have allergic does he have frequent itchy eyes? And the mother was like, hey, every day the eyes are itching. I said, oh, he disturbs us a lot with his nose, but nobody has picked it up and has treated it. So when you have an asthma patient, the allergic phenotype, they also have these associated comorbidities. So ask about them, diagnose them, and treat them appropriately. The fact that is underlined by airway inflammation, which is chronic, has been mentioned. So asthma is as much a chronic disease as hypertension, diabetes. So just like we don't manage our hypertensives for the acute episodes or worsen, asthma is not just about managing acute episodes. Asthma management involves ongoing management. Right. So let's talk about, let me say that the definition of asthma has not changed. The 2024 update did not change anything about the diagnosis. The diagnosis has remained the same since 2015 as far as I can remember. So let's look at updates on diagnosis. The approach to diagnosing asthma, as has been presented, has really not changed in the 2024 guidelines. The little bit they've added is to acknowledge that, the diagnosis of asthma is based on three things. One, typical symptoms. Two, airway obstruction, which is demonstrated by spirometry. And then reversibility of the airway obstruction. But GINA recognizes that spirometry is not available, it's not widely available, so they've made room for the use of peak flow. So they emphasize that though peak flow is not as reliable as spirometry, it's better than relying on only symptoms. Dr. Asmani talked about underdiagnosis and overdiagnosis of asthma. When you don't confirm asthma diagnosis with lung function test, with spirometry preferably, or at least peak flow, you stand the risk of overdiagnosing or underdiagnosing asthma. So peak flow is recommended for asthma diagnosis. I think Dr. Asmani tackled that, so I won't go into the details. So the guideline also talks about cough variant asthma. It's also a problem. Patients who would have been coughing for years, but they don't quite have shortness of breath. So patients with chronic cough with normal chest x-ray, one of the commonest diagnoses is cough variant asthma. The underlying pathology of cough variant asthma is the same as asthma, and the mainstay of treatment is inhaled corticosteroids. The guideline also talks about the assessment of asthma control. Again, Dr. Asmani talked about it. You see, as I said, asthma is as much a chronic disease as hypertension and diabetes. For our hypertensives, when they come to us, we assess their control with BP measurement. For our diabetics, we would check blood sugar or HbA1c. What about asthma? Studies have shown that we can overestimate or especially underestimate overestimate asthma control when we don't use objective means of assessing their levels of control. So asthma patients should have their control assessed. We shouldn't just treat them arbitrarily. How do we assess asthma control? It's done in two domains. One is symptom control, and the other is the risk of future events. What this basically talks about is that the patient sitting in front of you, how much of symptoms does he have? And number two, going from the clinic, what is the risk that you will have an exacerbation? So those are the two domains. So Gina recommends the use of questionnaires which assess the symptoms in the past 4 weeks. What I use at my clinic is what is called the asthma control test. It's a very simple questionnaire to use. It asks 5 questions over the past 4 weeks. It's freely available online. So you can search for asthma control test, and it actually assigns scores. It scores the patient's responses out of 25. 20 and above is well-controlled asthma. Less than 20 is poorly controlled asthma. So based on that, you can take decisions. The risk of exacerbation, there are a number of things you can do to assess. One of them is lung function test. At least you can use a peak flow meter to assess. Or some of my patients have their own peak flow meter. So when they come, they show me, they plot it on a graph, and you can tell whether they are doing well or not. So let's learn to assess asthma control. Again, the goal of asthma management has been presented. When a patient sits in front of you, an asthma patient sits in front of you, there should be a discussion on the goals of asthma management. Many asthma patients are used to having symptoms, and they don't appreciate the fact that asthma treatment has goals. I remember a patient I was attending to, a 9-year-old, and she used to have very frequent asthma symptoms. At least in a year, she would be admitted to hospital 6 to 8 times. Then, in my asthma management, I normally do a thorough job. So when it got to discussing the goals with her and the mother, I told the mother that asthma can be controlled. And when it's controlled, it means that your child may not have symptoms at all. The symptoms will be very minimal. And the woman just sprang up. Is it possible? Then he asked me that, Doc, I've been coming to this hospital for 6 years. How come nobody has told me? And I said, well, that's why you're at an asthma clinic. So when asthma is well controlled, it means patients have no symptoms or they have few symptoms, no sleep disturbance, they can play. Some patients will tell you, especially the children, the parents will be restricting them from participating in sports and other things. I keep telling the patients that that's why the asthma has to be treated. Because a child has to be treated so that he can enjoy all the things a child has to enjoy. There's no need to restrict an asthma patient because of symptoms, but rather treat the asthma patient well to goals so that they can live normal lives. Part of the asthma goals is to ensure that in the future they won't have exacerbations. There is this issue that has come up strongly, and I know it's a question that we all ask: can asthma be cured? Well, Gina emphasizes that asthma is not curable, but it can go into remission. And there are 2 types of remission, and they are clinical and pathological remission. The clinical remission refers to symptoms, where a patient for a specified period has no symptoms at all. The limitation in the guidelines now is that they don't give a specific period of time that you can say if a patient has been symptom-free within this period, then we can say this patient is in remission. Pathological remission is based on normal lung function tests. So if a patient has had normal lung function tests for some time, and also inflammatory markers have been normal for some time, we can say the patient is in pathological remission. But neither of these means cure. It has to be emphasized. So what about the update on management? These have been presented, but to sum them up, there are 4 key recommendations in the update with regards to asthma management. One is, as has been emphasized, no more salbutamol alone. It doesn't mean that salbutamol has suddenly become a demon, and it has no place in the management of asthma. The emphasis is alone. It's like Jesus saying, man shall not live by bread alone. If he had said man shall not live by bread, it would have been big trouble. But thank God for the word alone. So it's no more salbutamol alone. So what it means is that the mainstay of asthma management is to focus on the inflammation with inhaled corticosteroids preferably. Then also there is a place for what is called anti-inflammatory relief. The anti-inflammatory relief is for patients who don't have frequent symptoms. Let's say less than 5 or less symptoms per week. What the anti-inflammatory relief means, as Dr. Asmani said, these are patients who don't have to be on asthma, the inhaled corticosteroids every day, but as and when they need it. That is, as and when they experience symptoms. So I'll re-emphasize the point Dr. Asmani made, that not every asthma patient needs to be on Symbicort, Seretide, beclomethasone daily. Those who have less frequent symptoms can be on the medication as and when they need it. You see, the challenge here is what happens when the patient has come with an attack. How does this really play out? If a patient comes with an attack, it's different. A patient who has come with an acute attack going from the hospital must be on daily inhaled corticosteroid for some time, a minimum of 2 to 4 weeks, and it's all in the guideline. But a patient who comes to your clinic telling you that, oh, I have asthma, but occasionally I have chest tightness, that's where these apply. Then those who have almost daily symptoms will need to be on what is called MAT, maintenance and reliever therapy, with the same device. And that device must contain formoterol and then an inhaled corticosteroid. That inhaled corticosteroid can be budesonide or beclomethasone. And that has been said already. And then the fourth update is that currently asthma management has been, the lines of management has been categorized into 2. So we have the preferred management option and the alternative. The preferred management option is the option that is based on formoterol with inhaled corticosteroid. And with that, the reason why that is preferred is because of the molecule formoterol. Formoterol is a long-acting beta-2 agonist. And it's long-acting because it can keep the airway dilated for up to 12 hours, unlike salbutamol, which can do so for up to 4 hours. But the added benefit of formoterol is that in addition to being long-acting, it also has an early onset of action. So when you introduce a formoterol into the airway, it starts dilating the airway as quickly as within 3 minutes, similar to salbutamol. Salmeterol is the common alternative, but it doesn't have that ability. It also dilates the airway for up to 12 hours, but the onset of action is not short enough to be recommended as a reliever. So formoterol-based ICS can be used both as maintenance and reliever. So that patient needs only one device. They can use it daily, and then also when they have symptoms, they use it. The alternative track is where salbutamol comes in. That is those who, for one reason or the other, cannot use the formoterol ICS. A patient came to me recently and said, I don't like your device, because it makes me have, he said, I just don't like it. And I said, oh, fortunately, there's an alternative for you. So I put her on salbutamol and then an ICS LABA. So that is the alternative option. Right. So these are the key updates in the GINA guidelines. All these other ones, Dr. Asumeni has talked about them, so I'll skip them. So let me quickly do a case presentation. A 37-year-old woman who began to experience wheezing 12 years ago when she was pregnant. The symptoms were infrequent until 3 months ago, sorry. She had daily symptoms at the time, and it was interfering with her sleep and life. Unfortunately, her salbutamol inhaler was no longer able to relieve her symptoms. And the funny thing is that her symptoms started when she was pregnant, and that child she gave birth to also had symptoms. But this child, who at the time was 12 years old, was having only occasional symptoms. So how should this woman be managed? Here, she has not come with an attack. She has come to the clinic telling you she has symptoms. So where do we start her? Is it on step 1, step 2, step 3, step 4? Because her symptoms are daily, she needs daily formoterol ICS. So we need to start her on step 3. The child who has once in a while symptoms needs to be started on step 1, which is the same formoterol ICS, but as needed. Right. So I'll quickly go to the talk about the correct inhaler technique. Now, unfortunately, worldwide, many asthma patients are poorly controlled. And several studies have shown that one of the main reasons why asthma patients remain poorly controlled is poor inhaler technique. There was a study done in the UK where they assessed asthma control among patients who were on correct medication. And they realized that about 70% of them were poorly controlled. And one of the main reasons was that the technique of use was poor. Why is correct inhaler technique important? It's because asthma is a problem of the airway. Correct inhaler technique ensures delivery of effective doses of the medication to where the disease is, that is the airway. Incorrect inhaler technique results in inadequate delivery of the medication to the airway, and therefore reduces the therapeutic efficacy of the drugs and contributes to poor asthma control. So a study done by Choktu et al. Showed clearly, they studied patients with, asthma and their inhaler technique, and they could clearly tell that between those who had poor control and well-controlled asthma, there was nobody with well-controlled asthma who had poor inhaler technique. But among those who had poorly controlled asthma, many of them had poor inhaler technique. So they concluded that poor inhaler technique was a major cause of poor asthma control. So let's look at the various inhaler devices we have on the market. Many of them. These are, we have 2 main categories, the dry powder inhalers and then the pressurized metered dose inhalers. So this is, more of a dry powder inhalers. We can identify with the AccuHaler, which is very much on our market. We can identify the Tebuhaler. Elsewhere, there are others. I think there's also one that looks like this one on our market currently. Then we have the pressurized metered dose inhaler, which we are very much used to. So I'll start off with the technique for the pressurized metered dose inhaler. When you have this device, how do you use it correctly? There are a few steps, just about 6 steps to observe. First of all, this medicine contains a mixture of medicines in the canister. And when it lies down, they separate because they are not really miscible. So before the patient uses it, he or she has to shake it 5 to 10 seconds. Then after that, take off the cap. The next step, which is very important, is to breathe out maximally. The breathing out is so important, and studies have shown that it's one of the most critical steps that are made in the inhaler technique, because it expels the air and then clears the airway for the delivery of the medication. If a patient does not exhale maximally, the patient's chest is full of air. It will not allow the medication to go in and reach the airway. It's like having a balloon which is inflated and forcing air into it. So the next is to actuate the medication, and then to actuate is to pump it. And then as you pump it, you inhale it. And then when you inhale, the temptation is to breathe out immediately, but that's a big mistake. One has to hold his or her breath for up to 10 seconds, because the medicine will take its time to go down the airway to reach the airway. So very important. First, shake. Second, take off the cap. Third, breathe out maximally. Then actuate or pump the medication, and then you breath hold for up to how many seconds? 10 seconds. Then if the medication contains an inhaled corticosteroids, they rinse the mouth. The next is the same PMDI with a spacer. So we all know spacer. Spacer is recommended for the management of acute asthma. So for patients who have especially frequent asthma, you can give them spacers to use. How do they use it? They can only use it with this device, a pressurized metered dose inhaler. They can't use spacer with the other option, the dry powder inhalers. So what you do is they connect the PMDI to the spacer. The spacer has a slot for the PMDI. Before they connect, they actually have to shake the PMDI, insert it into the spacer. Then the patient has to exhale away from the device, then apply either the mouth part or if it has most of them come with face masks, so you apply the face mask correctly on the mouth or over the nose, and then you deliver the dose. Then the patient breathes in 5 to 10 times. Then after that, if there is a need to repeat, the patient does so. So they inhale 5 to 10 times. I know that there are other options. Some people will tell you, breathe in deeply, hold your breath. It also works, because that's what is on the American Lung Association website. But most literature recommend that you breathe in and out 5 to 10 times with a spacer. Then we have the dry powder inhalers. There are different types, as I showed earlier. This is called Turbohaler. So it has different parts. It has the cover, and then the main, it has a mouthpiece, and then the main chamber. And then the red part is called the grip. So that's what we use to turn it open and then turn it closed. Now, with the grip, they can turn it either way. One way gives a click, and that is what opens the device. The other way, which is silent, closes it. So to use it, very easy to do. You take off the cover, of course, and then when the patient gets it for the first time, there's a need to prime it before the patient starts using it. So how do we prime it? After you've taken off the cover, you hold it upright, and then you twist it to a click, and after that you reverse it. After that, the medication is ready for use. And then subsequently, the patient takes off the cover, open it by twisting the grip to a click. Then, similar to the PMDI, breathe out maximally. Then you put it into the mouth, form a tight seal around the mouth part, and then inhale it just once. So after you inhale, similar to the earlier device, you hold your breath for up to 10 seconds. So quite straightforward. And after you can close it and cover it. Then this other one is very common on our market. The AccuHaler is also a dry powder inhaler. How do we use it? So it has a place for the thumb. So you place your thumb on it. We call it a thumb grip. So use it to open it, and when you open it, it exposes the mouthpiece. And then it has a dose release lever that you press down to release the dose. And then after that, the process is similar to the other ones. The patient breathes out maximally, pulls the mouthpiece into the mouth, form a tight seal around it, and then inhale deeply, and after, hold the breath for up to 10 seconds. And then after that, the patient can breathe out. And because it contains an inhaled corticosteroid, the patient rinses the mouth. So this is another device that is on the market. So quite similar. The patient has to sit upright or stand upright, breathe out. Of course, you'll have to remove the cap. They breathe out similarly. And then with this device, the difference with the PMDI is that you don't press anything. You just inhale. And then you hold your breath for up to 10 seconds. After that, you cover it. And if it contains an inhaled corticosteroid, you rinse your mouth. So patients should always rinse the mouth after regular use. The rinsing of the mouth with inhaled corticosteroid is not necessary for patients who use it PR as needed. It is only necessary for those who use it daily. And then patients should always check the dose counter to be sure how much is left. Lastly, let's talk about how to assess an inhaler technique of a patient. The assessment of inhaler technique should be at every visit. At my clinic, no matter who you are, we assess your technique. Even if you're a professor of respiratory medicine, and you come to my clinic, you have to demonstrate the inhaler technique. And I can tell you that patients very often falter. Even patients who had the technique, some time ago, with time they lose it. So my boss, Dr. Audrey Forsen, used to tell me that, Alan, you always have to assess patients' inhaler technique because they tend to forget. And it's really true. So what I recommend for the assessment of inhaler technique is what is called the Inhaler Devices Assessment Tool, which is a well-published and validated way of assessing inhaler technique. It applies to all devices, and it assesses 5 steps in the inhaler devices use. So first step, does the patient open the device correctly? So if it is a PMDI, do they take off the cap? Do they shake? Or if it is a PMDI, they have to shake. So do they shake it? If it is a dry powder inhaler, they have to prime it.
Thank you, Dr. Steele Dazi. I think we've been trying to catch up with time. And indeed, it's been a very educative session. As for inhaler technique, it's a big area, even for clinicians, and how we try and demonstrate to our patients. So sometimes when the patients get it wrong, we are not sure whether to blame them or to blame the clinicians. Sometimes when we don't teach them also, and we ask them, go to the pharmacy, the pharmacist will teach you, you'll be surprised. The kind of education that goes on there. So we'll take this important message. We wish it would have been practical and not all, we had a theoretical demonstration of the other types of inhalers, but we'll surely get a practical demonstration of the use of Symbicort. That is the sponsors of this program. Indeed, we need to remember that the diagnosis of asthma is clinical, but we always have to get the support to demonstrate the airway or airflow obstruction. And that's where the spirometry or the peak expiratory flow comes in. Remember to make sure that you discuss the goals of asthma management with your patients. It's time consuming, but you can do this for patients who you label as having acute asthma. The mild ones, sometimes they are okay. And so where you have you're hard pressed for time, focus on those who are not doing well. And I also want to state that there's something we call the Asthma Action Plan. Now, interestingly, some schools are demanding that clinicians write an asthma action plan for some of the students. We will have this developed. It will soon be on the GTS website, so it's easier to just download, just click and fill whatever you want to put in. There will be a template for us to look on to be able to do this for our patients. And let's remember that poor asthma control is almost synonymous with poor inhaler technique. Thank you very much, Dr. Steele Datsey. A round of applause for him again. And I think that we've been sitting for a long time, so we would step up out a bit for a short tea break, just 10 minutes, and then we can have the most important, which is the questions and discussion group, what I think will be most beneficial. Thank you very much. The break is out. It's this way. So let's please stand up and exercise our legs a bit. Thank you.
Imagine if you're underwater and you're trying every effort that you can to gasp for breath, and that desperation, as if you're trying to come up for air. Having an asthma attack, it's really hard to explain when I'm well.
It's kind of like having someone put an anvil on your chest and you can't breathe because of that weight on your chest and you cannot get it off.
It feels like someone's kind of choking me, and then I start coughing. I sound like a monster, kind of, and it's exhausting.
Until you see what it's actually like to have a full-blown asthma attack, you cannot make people understand when you say, I can't get down the stairs, I can't feed myself, switching the nebulizer on. I literally can't do that.
People think it's the physical things. It's not just that. It's going to the movies, it's going to the mall, it's walking the dog. It's just normal, everyday things. So yeah, it is very much an invisible disease.
Asthma is the most common respiratory condition in the world, but severe asthma is more about day-to-day symptoms, frequently 365 days of the year, and it's a variable condition. So it makes it really hard for people to plan their lives. It must be a truly terrifying experience to not know how well you're going to be on a day-to-day basis and not know whether the next attack is going to mean that you're in intensive care.
I've suffered from asthma ever since I was 18 months old. So it's kind of all I've known, and I did spend so much time in hospital. A friend that I became really good friends with from the age of 14, she was just on 4-hourly nebulizers, started coughing, she started having a bit of an attack, and she said, I'm gonna have to walk to the nurse's station. And then the next minute she arrested. And it was so scary, so scary. And this is what I think is important to know, because you can be fine 1 minute and absolutely not the next.
We wanna praise you, praise you, praise your name. We wanna praise you every day.
From almost first week, she had eczema. So when she was 9 months, we did the first test.
My asthma problems kind of evolved when I was like 10 maybe, and I started having problems while playing soccer. I had my first asthma attack during the pollen season. After that, it was kind of a bad spiral. I have quite extreme allergies. All of my allergies triggers my asthma. Pollen, dust, cigarette smoke, perfumes. I don't think people even think about that smells could make someone ill. Taking the bus to university, there's always someone that just smoked or puts on way too much perfume. I'm studying to become a biomedical scientist. I love learning new things, and I've always wanted to understand what is wrong with me so I could know how you possibly could fix it. And I think that meeting patients when you've been a patient, I know how it is to sit in the chair that my patients will sit in, and I know how it feels to have heavy breathing, and I know how it feels to be nervous when you're going to the doctor.
It took many, many years for me to actually be diagnosed with asthma. I would get sick, I would go to the doctor. He would give me antibiotics for a sinus infection, and he would give me a puffer to help my breathing. And this went on, and it got more and more frequent. And then he would give me an oral steroid. And then a few months later, it would happen again. And he finally got to the point that he said, "You're not getting better. We need you on these all the time so you can function."
The oral steroids, they have saved my life many times. They have terrible side effects, they're really awful. They would give me a bloated face, bloated stomach. I can't sleep because of them. They affect your mood. You can feel that mood coming over you. I now have been diagnosed with osteoporosis. They're just not nice.
There's no magic bullet. There's no simple diagnostic test. There's no treatment that's going to fit everyone. And I think where we are now is we've got multiple different treatments. Because we've had oral steroids for a long time, it's very easy to be relatively relaxed about them. And because we also see that they do save lives. But invariably when people come and see me, their number one concern is the oral corticosteroids. And their number one question is, how can I get off these drugs?
Yeah, this is me coughing. having difficulty breathing. This is one of my best friends. And one of my worst enemies. Cortisol, everybody. My severe asthma attacks is that I don't react the way you're supposed to do. Then you come to the doctor and she tells you that you don't have a problem. And every time after that, I've like postponed going to the emergency room.
People would come and they get upset that it had taken so long to get to someone who understood what was causing the symptoms, and the only way that people can really get the care they deserve is to be put in front of someone who actually understands that, sees that on a regular basis, and isn't going to tell them, actually, I think you're okay.
I just feel that I've slipped through the net. When I was 17, I was diagnosed as one of the most severe asthmatics at that time. I'm now 40. And I've been suffering all this time. And to go to have a DEXA scan last week and to be told how bad my bone density is at the age that I am.
I've just come out of the doctors. The news wasn't great. My bone density is very, very low, really what it should be for someone twice my age. I've now been put on more medication. Here's my shopping bags for today.
And there's no going back from osteoporosis.
When people have more severe asthma, we know that you really need to see a specialist. We need to get much better at making that initial diagnosis in primary care. And the early referral is particularly important now because we have lots of new treatment options. Not perfect, we're nowhere near talking about cures yet, but we have treatment options that allow people to live their lives again.
When we moved to the specialist, the care was much better there.
It was like flipping a coin for me. They listened and they took a lot of tests. After that, we changed my whole medication and it got a lot better.
My doctor was very good because when it got to the point where he felt he couldn't get things under control and I was too sick, he sent me to a specialist. I'm so incredibly grateful that now my asthma is so well under control that it doesn't hold me back from anything anymore. On March break, I had 3 of the grandkids and we were skating and we went to PlayFit and we went to a butterfly conservatory, and I never would have considered going in there before because the humidity would have sent me spiraling. And now I just, not a problem.
I've always loved to sing. It strengthens your lung functions. It's amazing. It's kind of been something that I've been able to do no matter what.
Frida is extremely positive. She's not staying at home just because she's afraid. And that's a great way to live.
One of the best things about being a severe asthma doctor is we can truly transform lives. Because people come back to me now and say, thank you, I've got my life back. I walked my kids to school for the first time ever. As a human being, let alone as a doctor, that's just such a wonderful thing to happen.
Before, when my asthma was very bad, I was afraid to go out kayaking by myself. There's nothing that stops me now. I do whatever I want. If I want to try something, I'm going to try it, and having severe asthma doesn't hold me back anymore. The greatest needs for people with severe asthma is to be properly diagnosed by specialists. And if the proper diagnosis is made early on, perhaps they won't go through the years of suffering that I did.
presentation, then he takes over the discussion. Then
Yeah, good evening once again. So shortly we'll be starting the second session for today's event. So for those of us still having tea breaks, maybe we would ask that you take your seats as we start the second session for the Asthma Forum. So next item on our program today is a presentation from AstraZeneca by Prince Abuaji on Symbicort device usage demonstration and turbohaler benefits over the other devices. So with a round of applause, let's welcome Prince Abuaji.
Good evening once again. So I believe it's been an insightful journey with our speakers, taking us through the diagnostics, also with the benefit of inhaled corticosteroid and formoterol combination in managing our asthma patient, as well as the role budesonide also plays in emergency management of asthma. So from AstraZeneca, we follow the science and we believe in what science can do. And with our innovative medicine, we have Pulmicort Nibble that comes at 0.25 and 0.5 milligram in acute management of asthma at the emergency level. With Pulmicort, it has a fast onset of action within 6 minutes, and because it has a high water solubility, it also increases the bioavailability of the drug. So this informs the absorption time of the medication. And we also made mention of, Dr. Pabi made mention of the vasoconstrictive effect of budesonide in asthma management. And this has been shown also here with Pulmicort, with a strong pulmonary vasoconstrictive effect within 30 minutes compared to beclomethasone and fluticasone. With this effect, when you look at the asthma patients with asthma within the airways, there are dilated pulmonary blood vessels, which leads to increased blood flow and swelling and inflammation and mucus secretion within the airway. So once this vasoconstriction takes place, all these effects or activities are reversed and the patient gets better. Now with Pulmicort, it's as effective as your systemic corticosteroids. So if you look at the IV hydrocort or IV corticosteroids and the oral steroids that are used, with the days of disappearance of wheezing, the days of steroid use, or the days of oxygen use, is as effective as these systemic corticosteroids. The most important thing is that when it comes to Pulmicort nibbles, serum cortisol suppression did not even occur with high doses of nebulized budesonide. And this is very important because when it comes to serum cortisol level, it informs or has impact in the growth of children with their height, their bone mass and all that, and general well-being of the children. So once there is less significant impact on this serum cortisol level, it actually indicates that it's safe in use in children. With Pulmicort, it also ensures that there are shorter length of hospital stay with our patients. Once you are adding it as part of your treatment regimen, you know that the number of cycles that you are going to do with your back-to-back salbutamol hypertropium is going to be limited. You are going to get an effective and faster response for your patients. With our patients coming to the emergency units, most instances, parents are there with their children. They should have been at their workplaces, having some productive time and earning some revenue for their family. Children also would have to play and be in school and be with their friends. But the longer they stay at the hospital, we are depriving them of all these benefits. Now, it's important for us to also take note of the dosage and how we prescribe Pulmicort for our patients. So with Pulmicort, with the 0.25 and the 0.5 mil, it comes in 2 mils. So if you pick the 0.25 milligram, 1 mil of it is giving you your 0.25, 2 mils of it is giving you your 0.5. If you pick 0.5 milligram strength, 1 mil is at 0.5, and 2 mils is going to give you 1 milligram. Your initial or start dose for children is 0.25 to 0.5 milligram. And for adults, is 1 to 2 milligram. And Pulmicort is also given BD, that is 12 hourly. So it's not like your salbutamol hypertropium that you do back to back. Once you add it as part of your start regimen, if you have to give again, you do it after 12 hours. So in summary, with our Pulmicort, it's compatible with hypertropium and salbutamol nibbles. It has a faster onset of action, gets directly in the airway where it's supposed to work, and also it offers a convenient way of administering your medication with less systemic side effects. Now moving on, we also have our unique and simple to use device, that is the Symbicort Turbo Haler. And with the Symbicort Turbo Haler, it comes as 164.5 and 84.5. The 84.5 is from 6 years to 11 years, and the 164.5 is from 12 years and above. And I believe as we went through the GINA guidelines, we came across the ICS for formoterol as maintenance and reliever therapy. So Symbicort serves this purpose for our patients with one device that they can use for both relief and maintenance. With a combination in there, that is the formoterol, that is our long-acting beta-2 agonist. It has a fast onset of action within 1 to 3 minutes. So it's as fast as our Sabes, that's the short-acting beta-2 agonist. And it's staying longer for 12 hours in the system. Then also budesonide has a rapid dissolution rate into the mucous layer, given that rapid airway response that our patient need to get relief. So that's occurring within 6 minutes. Compared to Sabes being used as relievers, as earlier mentioned, Symbicort is tackling the underlying inflammation with the budesonide in there, and formoterol addressing deconstriction of the airway as fast as the Sabes with a prolonged effect. So with Symbicort, you're actually protecting your patients from frequent attacks as they would experience. Symbicort has demonstrated a superior efficacy in reducing the rate of severe exacerbation versus higher dose of ICS LABA and SABA combination. And that is reduction of 39% effect. And also with less ICS or inhaled corticosteroid used. So if you look at the whole action or how Symbicort is working with your patient, if you pick the lung function, once you are initiating Symbicort for your patient, you are improving the lung function, you are addressing the underlying inflammation, and also reducing the symptoms that would occur with our patients. Symbicort has a high lung deposition with, of 38% compared to other medications or other inhalers that are used. So with this fine particle size, the drug is driven directly into the airways, giving the patient the effect that they need. So I'll quickly take us through how the device is used. And these are the 3 steps that I would want us to remember as we leave here today. And that is twist, click, and inhale. These are the 3 steps to this. So on our tables, we have the turbo haler. So every table has 2. So we can pick it and do it together. Okay, sure. So we are doing this together. Thank you. So first of all, let's lift our devices up. Okay. There are 3 parts of the device: the mouthpiece, the dose indicator, and the loading ring. So first, we will take the cover off from the device. So let's unscrew it and take the cover off. So the top part is the mouthpiece. Then at the side, you'll see the dose indicator. That is 120. Please, can we see that? And there's the loading ring. Now, the first thing that the patient has to do with this device is to activate it. Now, to activate the device, you twist the red grip or the red ring in one direction to hear the first click. So we are doing it together. Please, have we gotten the first click? Now, this means that the device is activated. And now we are recommending that at the pharmacy or at the dispensary, this is done for the patient. And even the first inhalation is done at the pharmacy before they go home. So once this is done, then we look at the prescription that has been written for the patient. So if it's one morning, one evening, we are going to go through that. So we are going to twist this red grip as far as it to go in one direction again. Then bring it back as far as it to go in the opposite direction. So we hear the click sound. Once we hear the click sound, the patient has to breathe out gently to clear the airway. Now put the device in their mouth, the mouthpiece. Then take in a strong, deep inhalation. They hold their breath for about 5 seconds. Take the device out gently and breathe out. Now to load the second dose, they go through the same procedure. Twist as far as it to go in one direction. Twist as far as it to go in the opposite direction till you hear the click sound. Breathe out gently and put the device in their mouth. Make sure it's well sealed and take in a deep, strong inhalation. Hold your breath for about 5 seconds and breathe out gently. Now, at the pharmacy, we advise them that with Symbicort Turbo Inhaler, they are unlikely to taste anything in their mouth. Because of the fine particle size, it's driven directly into the lungs and is offering them a maximum lung deposition. So with Symbicort, unlike the other ones that they feel that or taste the drug in their mouth, we inform the patient that they don't taste or they are unlikely to taste anything. Now, with the dose indicator in here, for them to see a significant move in the dose counter, they should have done about 20 times for it to move from 120 to 100. So the numbers are actually done in 20s. So from 120 to 100 to 80 to 60, 40, and 20. So let's do 20 clicks, twist click for about 20 times so that we see that significant move. So quickly we can do that. I think we are enjoying the play. Oh, have we gotten 20? Can we see the significant move? Please, can we see that? Yes. So this is what we have to inform our patient that if today is Monday and they are doing 2 inhalation in the morning, 2 inhalation in the evening, that's 4. So by Friday, they should have done the 20, and that's where they are going to see that significant move. If they want to see if indeed there is a drug in there, they can do the twist click, pick a black cloth, turn it over, and shake it. They will see a white powder in there, but it will mean that you are wasting the medication. So most importantly, to assess if you've really gotten the dose that you've taken, 1, ask yourself, am I experiencing the symptoms that I used to experience? Have I gotten the relief that I need at the point of administration? And that informs that you've taken the medication. So with Symbicort, that is simply how to use our device. Thank you very much. So I believe we've gotten this clarity. The other last bit to do is the counseling point. At the dispensary, what do we tell our patients when they are going home? Because there is an inhaled corticosteroid in there, they have to rinse their mouth at the end of the day. Okay, and to care for this device, you clean the mouthpiece with a dry tissue. You don't wash it. With a dry tissue, you clean the mouthpiece, then replace the cover with it as they go home. And importantly, Symbicort is covered by our national health insurance. So the 164.5 is covered by NHIS. So in all government facilities, if you prescribe for your patient, they will get it covered on insurance. Thank you.
Thank you very much, Prince Abuaji, for your very informative presentation and taking us through how the table healer, which is the option, the solution to our patient management of asthma in terms of control as well as relief is concerned. We will therefore move to our next session where we have a panel discussion. And to help us share or gear the discussion is a family physician. He is a senior family physician with Kolebu Polyclinic. He is currently the national president for the Society of Family Physicians of Ghana from 2021 to date. He's a faculty board member of the Ghana College of Physicians and Surgeons. He's a part-time lecturer who lectures physician assistants, preparing them to write their certification exams, and is a member of the Medical Knowledge Fiesta Planning Committee. Ladies and gentlemen, help me welcome Dr. Nketia.
Thank you very much. I think that for me, I see this as one of the most important sections because all the time we have these lectures, but people have pertinent questions that, they want our resource persons to actually answer for us. And these are questions that have been tabulated from all over the country, from primary care physicians, what their challenges are. And I'm very glad that we have this lecture, and I think that it's been very elaborative, but we'll be going to the little details to see where the challenges are. We'll also be taking online questions, so our online audience, kindly put your questions there. As we go on, we'll add it to it. But to help us with these questions is our very able 3 resource persons. My own good friend, Dr. Stildazi, please, if you could take your seat. My very good friend that I left at 37, Dr. Pabi, our pediatrician. And our able respiratory physician, Dr. Asmani, please, you could take your seat, please. I'm sure that they've given us enough, but there are other aspects that I'm sure are challenging for us. One of the questions that came quite interesting, I think this one, I'll give it to Dr. Stildazi. They went through a very nice way of diagnosing asthma. But a lot of times, by the time in Ghana, by the time the clients get to you, they've taken all sorts of things. They've been to the pharmacy, they've called their doctor friends, they've gotten medication themselves, and the scenario really may change a little bit. So when they come like that, somebody, probably they've even been to the emergency place, they've only been given nebulization salbutamol, they got better, they've gone home. How do you confirm diagnosis? And let me add this to it. A lot of times, at the emergency place like that, people are confused whether is it a cardiac asthma, is it a COPD, what is it? How will you confirm this one so that you can be sure that it is asthma that I'm dealing with and I'm going to manage as such and continue as such?
Right, thank you very much. Thank you, Dr. Nketia. So basically, as we said, the diagnosis of asthma is based on 3 things. Number 1, the symptoms or the clinical presentation and whether they are typical of asthma. So we talked about the 4 main respiratory symptoms. In fact, all symptoms of asthma are respiratory. And there are 4 main symptoms, so we talked about them, so no need to belabor them. But then you also look at the pattern. Typically, asthma will have, it will be triggered by symptoms, various triggers. In Ghana, the commonest triggers are dust and strong scented perfumes. Some also have it exacerbated by or triggered by exercises or physical exertion. It tends to be worse at night. So when patients have all these, then you confirm with your lung function test. So the lung function test we've gone over. So normally, if you have the facilities, you refer the patient for spirometry. And normally the spirometry is interpreted, so they'll tell you whether the features suggest they are asthma or not. But when spirometry is normal, it doesn't mean that the patient does not have asthma. You can repeat the spirometry at some other times. But we also talked about peak flow, which can also be used. But to the specific question as to what to do when a patient has taken some medication for a while, I think the main challenge is when the patient has taken inhaled corticosteroids for a while. And let me say that in that regard, in fact, we shouldn't delay needed asthma treatment just to confirm asthma diagnosis. When a patient needs medication, including inhaled corticosteroids, we should prioritize the need for the medication. And then we can later think about confirming the diagnosis. So if a patient has been on inhaled corticosteroid for some time, when the patient is well controlled and we really want to ascertain whether it's asthma, we can let them go off the inhaled corticosteroid if it is safe. And then give them about 4 weeks. And then they do the lung function test or spirometry. Or peak flow, sorry. Spirometry or peak flow. And based on the parameters as has been presented, we can decide whether they have obstructive airway disease or not. So that's basically how to go about it. But let me also say that the sensitivity of symptoms alone for diagnosis of asthma is very high. There was a study that I came across that demonstrated that when you rely on symptoms, the likelihood of getting asthma right, especially when the symptoms are typical, is well over 80%. So when you don't have access to lung function tests, you can't diagnose asthma to a satisfactory degree. Thank you.
Yeah, thank you very much. It says that if you don't have spirometry, especially for our colleagues out there, some of them are village Kokotro, with no spirometry, you can use the symptoms, the cardinal symptoms, and probably if you are treating and they are doing well, then you could. Dr. Pabi, one of them actually said that in children it's very difficult to diagnose because there are a lot of mimics. So how do you do it? Because I know you have a lot of cases that you are sure they are, but how do you actually come up to say that this child has asthma? 3 years, 2 years, 4 years, 5 years, trying to do away with the mimics.
Thank you very much. So, like you said, that is very true. It can be very challenging in children, especially if they are less than 5, because there are a lot of mimics. You have any viral infections that they have, upper respiratory tract infections, it may mimic asthma. Foreign body aspiration, at that time they are very notorious or they are very active. I shouldn't call my angels notorious. I mean, they are very active and curious, so they pick anything, they put in their mouth. So foreign body aspiration may also mimic asthma and what have you. However, for us, basically, it's more of symptoms, the symptoms that we use there. So history and then your history of the symptoms and then your examination findings is what we rely on most. And so typically, the history of allergies, family history of asthma, and then you examine for any signs of allergies, allergic conjunctivitis, allergic rhinitis, and what have you. And then also maybe episodes of the difficulty in breathing, and as to whether there were maybe preceding symptoms of upper respiratory tract infection or not. So for typical asthma, if it is not probably triggered by an upper respiratory tract infection, then it will be sudden onset of the respiratory symptoms. So there will not be any preceding history of upper respiratory tract infections, like runny nose or flu-like symptoms. So they come in with the sudden onset of difficulty in breathing, which gets resolved when you I mean, you nebulize them with maybe the short-acting beta-2 agonist or the asthma medications. So once that improves, then it tells you that this could be asthma. But if it's the first time, you may not be able to tell. So you manage them as such, start educating and probably prompting them that this could be asthma. But of course, it's a bit early to tell because this is the first time. For me, I said that if you have such episodes 2-3 times, I will label you as being asthmatic until probably you are at a stage where I can confirm with the spirometer. Normally, we request for the spirometer when they're about after 7 years. That's where we tend to request. Before that, it's very difficult for them to, even around 7-8 years, it's still quite difficult for them to perform the test very well for you to get an accurate result. So mainly we diagnose them by their presentation, the repeated episodes, and then when you are old enough, you do your spirometry, and then also your response to the treatment.
Thank you very much, Pabi. So what is saying that don't wait till you confirm at 9 before you put them on the correct medications. My brother asked my name.
Can I add a bit to that?
Please, come in.
So another thing we can do is to do what we call clinical probability assessment for children. So there are 4 things you look at. As Dr. Pabi has said, the symptoms. Are they typical? And then you also look at the presence of allergic comorbidities. So the child who has the symptoms and has allergic comorbidities, itchy eyes, rhinitis, has a higher probability. And then response to treatment, as Dr. Pabi said, if they respond to asthma treatment, it makes the probability higher. And then fourthly, do they have a family history? So the more of these features a child has, the higher the probability. So you can conclude by saying that this child has a low probability of asthma, this child has a moderate probability of asthma, or this child has a high probability of asthma. And studies have shown that the higher the probability of asthma, the more likely it is that the child's asthma will persist into later life. So the probability assessment is also a very good way of diagnosing asthma in children.
Thank you very much, Sudazi, for the addition. So I had a client who actually came. This one, client that they've told that he's known to have, and the son is known to have asthma. A lot of people think in the village, and those of my colleagues out there, they think that, it's actually witchcraft. How do you explain the causes or the cause of asthma, the risk factors and the triggers? I always talk about the trigger because a lot of times we do not tell the clients the triggers. They go out there, they get themselves exposed to these triggers, and they come back. So one, what is the cause? So the client has come. What is the cause? How do you go about it? The risk factors that put them around, also the triggers.
Right, thank you very much. So as we said, it's one of the chronic airway conditions. So it's not, spiritual. This is a physical illness. All right, one of those common conditions we see. And as I said in the intro, every, practice is likely to come into contact with asthma. So from children to geriatrics, you meet them. So it tells you that it has nothing to do with superstition and so on. Right. And we think that there is some genetic, predisposition. But as we always say, the genetics load the gun, but you need some environmental stimulation to trigger it. So somebody may have genetic predisposition, but may not necessarily manifest the disease. You need certain things in the environment, which would trigger and prime the airway to become hyper-responsive and therefore behave like the phenotype we are describing as asthma. So we need to let this person know that this is one of those diseases, and it's not something that is just, based on superstition. And the triggers are varied. It depends. on a number of things, and some of them are very innocuous. So some of them are allergic in origin, and from, as he mentioned, common viral infections, upper respiratory tract, probably one of the commonest. And then apart from that, a number of things, apart from that, mold, even mold. So people get to a moldy, environment, or the room is damp and moldy. That alone can also be a trigger. And some components in food may trigger allergies and then so on, and then involve a trigger of the asthma. And then some irritants, like as he mentioned, dust. The Ghanaian cohort, dust, some people seem to have problem with that, and then also smoke, and then spray, all manner of spray, mosquito insecticides and body sprays and so on. We shouldn't also forget that exercise, especially young people, sometimes they get breathless when they begin to exert themselves. So exercise may worsen or precipitate that. And so some people will be able to clearly tell you. Others, you have to help them by asking questions before their mind comes to that. And of course, people who also buy drugs in Ghana, over-the-counter medications, especially pain medications of the NSAID nature, may precipitate that. And even prescribed medications could also be a risk factor to precipitating that. We had a patient who was wheeled into our clinic from cardiology. This is somebody who had asthma childhood and said to have, as people say, we know is in remission. He has grown out of it and developed peripartum cardiomyopathy at 30 years. And cardiologists have managed, chest is always having bronchi. So they felt that what is wrong? They questioned her and then got to know that she used to be asthmatic. What precipitated that she had been started on a beta blocker. So that was a problem. And they had done everything, and this person is always having bronchi. The pida edema is gone, but it's still, so drugs, we shouldn't forget that drugs could be a very good thing. And so a number of, somebody, even emotions, somebody gets, Dr. Forsen used to have a patient when the month is past the mid and, pocket is dry, then the asthma will worsen. All right, so emotions, strong emotions, when you are sad, some people, and then when they are highly elated. So it varies from person to person.
Thank you very much. We shouldn't forget to let our clients know about the triggers. Otherwise, they go out there, they get exposed to the same thing, they keep coming. So let's kindly do that. Let me come to you, Dr. Studazi. I'm sure you've worked at the primary care center where we see a lot of emergency cases. But I'm looking at all the primary care centers. I mean, people are wheeled in. Some are mild exhibition, some are going to severe. There's stages as to, we've only talked about nebulized salbutamol and the steroids. But of course, there are times that they come and realize that what I'm doing is not working. And I know it's asthma. How do you go on? And at what point do you say that, I need to refer to Dr. Asmenu, where they have probably some ICU to help and other people to support?
So basically about management of acute asthma. So as Dr. Pabi said, it's very similar, for adults and adolescents. So if you have a patient with acute asthma, there are some objectives that you should observe. Number one is to quickly assess the asthma patient. And the assessment should lead you to the next step, which is to categorize the severity of the exacerbation. And then after you've categorized the severity of exacerbation, the next step is to treat. And you have to do this in quick succession because the patient, as we know, is in a bad state. And with regards to the management, there are three main lines of management, which Dr. Pabi covered. One, you give your oxygen if it's needed. And let me say that all severe cases have to be given oxygen. And then you give bronchodilation and then corticosteroids. When it comes to the categorization, it's based on clinical features and then some measurements that we do. So first of all, how does the patient look like? Is it a severe symptom? Are they very breathless to the point that they cannot speak, make a sentence without taking a breath? All of us can make sentences without pausing to catch a breath. But if the patient can't do that straight away, that patient has a severe symptom. How is the clinical examination findings like oxygen saturation? Once oxygen saturation dips below 95%, that patient moves to the severe category. So mild is when the patient has the symptoms but doesn't have any of those parameters. Pulse rate is less than 100, or at least it shouldn't be less. It shouldn't be more than 120. So those without those features, with exacerbation but no features, we categorize them as mild, moderate. Mild, moderate come together based on our guidelines and that of the journal. Those who have any of the severe features, as Dr. Pabi emphasized, you don't need many of them, only one. If the patient struggles to speak, that is enough to categorize the patient as severe. Then there's a third category, which is the near fatal. That is when the patient is at risk of death. And those ones are characterized by respiratory distress, the oxygen saturation is low, and sometimes even carbon dioxide is elevated. Patients may sometimes even have altered mental state. So straight away, those patients are in life-threatening state. So the lines of treatment, bronchodilation alone may be okay. Bronchodilation is for all of them. And with bronchodilation, the options are either you are combining salbutamol with ipratropium bromide. If it is mild moderate, you can only do salbutamol. But if it is severe and life-threatening, you would necessarily have to combine salbutamol with ipratropium bromide if available. You have to co-administer with your inhaled corticosteroids or nebulized corticosteroids if available. Then you have to start your corticosteroids, systemic corticosteroids, as soon as possible. What is preferred is oral prednisolone, but if the patient, for one reason or the other, cannot take oral prednisolone, then you can start with IV, hydrocortisone, and then later you give them a full course of the oral corticosteroids. But patients who have severe and life-threatening, you start by all means, the management by all means, but as soon as possible, you have to refer to a higher center. At the primary care level, if you have a patient with near-fatal asthma, even if you start the treatment and they seem to improve, as much as possible, refer them to a higher center. Thank you very much.
Higher center, wow. I'm talking about my friend in one of the districts where the distance between the next facility is 2 hours. Dr. Smith, I've seen a lot of people trying to use aminophylline, max sulfate, and other things. Can you elaborate before they do, what should they do before they send to you? When actually there's a long distance before they get to you, and what are the things that they can try before probably they get, because so that is ending as ipratropium, but I know you can go sometimes further whilst they get to you, or you think that they should just stop there and get them in the ambulance to you?
Well, I believe that most primary centers are able to have access to the labels. Salbutamol is available, and then probably some centers may have, as you mentioned, ipratropium, and then at least systemic corticosteroids, even if they don't have the labels, they probably may have systemic corticosteroids. Now, over the time, aminophylline, we in third world country have had to rely on that. But you see, it has been noted to have issues, okay, especially where you cannot monitor closely then it becomes a bit difficult, you know. But a situation where that is all you have, then you can't say you won't give it, even though recent guidelines suggest that aminophylline, you know, especially where you cannot, monitor cardiac parameters and so on, you probably will not give it. For instance, in the tertiary center, that will not be your choice. But if you are elsewhere, that is all you have. You know, you can give it, but we say that don't give it as a bolus. You never give IV aminophylline as a bolus. You give it slowly. If you can't sit down and give it over 30 minutes, it means that you probably will have to give it through an infusion and allow it to go for, like, say, 4 hours. You know, a medium like normal saline, normal or DNS can be used, but you never give it like the way you give it at a shot. You could end up precipitating unnecessary arrhythmias and probably lose your patient. If that's the thing you have, probably you can, whilst the patient, you know, I'm hoping that wherever you are, you should be able to reach a district facility, or if it's a district where this is happening, then probably a regional facility on call or something, so that they know that this is a situation. But by and large, even though recent guidelines don't support, you know, using aminophylline as a primary way of treating acute exacerbation, we in third world countries oftentimes have had to rely on that. And most of guidelines, for instance, don't support, especially where you're not sure of the, what the phenotype is, to even think about whether the person will respond to even adrenaline. Some people have tried, especially where allergies in children, have tried to, you know, give subcutaneous adrenaline and got some relief, you know, but at least beta, short-acting beta agonist, ipratropium is there. Max sulfate is a first line. So most secondary centers will have max sulfate wherever they do deliveries. Max sulfate, I think, is one of the common medications, every facility that does deliveries and so on, because of preeclampsia, yeah, and it's available. So you give, we in adult 1.2 to 2 grams. You give it over, like, slowly over 30 minutes, and once you've given your back-to-back salbutamol, your next level is you are going to max sulfate, and you give this, then probably you would have arranged for this patient to be taken to the next level. But as you suggested, we still have aminophylline in the system. And if that's all you have, don't give it as a bolus. You may give it as an infusion.
Thank you very much. I think one very important thing is that max sulfate is available, and it's preferable to the aminophylline because of the side effects. So, let's know the dose so that when we are hot and you've called Dr. Asumeni, you can at least start your max sulfate and push. Dr. Pabi, action plan. A lot of times we have clients who come to us, acutely we manage. We just let them go home, only to come back the next 3 days. They go home, only to come back 2 weeks. We don't give them any action. Can you really elaborate on action plan, what it is about, what we have to do, just to make sure that at home they know what to do before things get worse?
Okay, so action plan basically is about empowering the patient to be able to take care of him or herself well. First of all, to make sure that he doesn't even get the exacerbation in the first place. And then if it does happen, the steps that he should take, what he should do before probably he gets to you. So first of all, identifying the triggers is one of the things. You have to help the patient to be able to identify what the triggers are. Once that is noted, and then you have to also take them through how to avoid them, to be able to avoid those triggers as much as possible. Then also, now you show them the symptoms that they are supposed to look out for. Because sometimes the symptoms may begin, but they will not do anything about it until it gets worse. So you help them to identify the symptoms that they tend to have. So once they start, so for us in our clinic, we tell them, once your child starts sneezing a lot, you should know that probably he's been exposed to something that he's now reacting. So start doing something. Don't wait for it to get worse. Then the cough and what have you. So you take them through that. And then also, once you know that they are having an attack or they are likely to have an attack, what should you do? You start using your bronchodilator or your beta-2 agonist. Of course, those who are already on the inhaled corticosteroids, that one, they are using it daily. So if you think you are going to have an attack, then you begin to use your beta-2 agonist and then observe. Those who are get the attack by maybe exercise. You know, my children, they like jumping around a lot. So, and they want to play soccer, they want to do this. So you always encourage them, maybe use your salbutamol before you go and play. And then when you come back also, repeat it maybe 2 to like 4 puffs before you go and play, and then after you play. So you take them through all this. So these are the plans that they have to take, or the actions that they have to take, either to prevent them from getting the exacerbation, or when they get the exacerbation, what they should do. And we tell them, once you use the salbutamol and you repeat maybe after 15 or 20 minutes and you are not seeing any improvement, then of course you have to be on your way to the nearest facility to be attended to. And then also, of course, we always ask them to make sure that you have your salbutamol around you wherever you find yourself. One of the things, especially in pediatrics, is that for me, all my patients, I advise them to get the spacer device, irrespective of how old you are. Because I can assure you, if we put all of us here to test, to use a metered dose inhaler right now, I'm sure more than half of us will fail. If you take you through it right now and you say you do it and let us see, you will still fail. Even the adults, they fail. So a technique of using the metered dose inhaler, it's so important. If you don't ensure that they know how to use it and use it well, you may not help your patient that much. So for me, for pediatrics, always use a special device if you are using a metered dose inhaler. So by like these are the things that we take them through: identifying the triggers, avoiding them, identifying the symptoms, starting your treatment, and then making the move to the facility. Thank you.
Thank you very much, Dr. Pabi. Dr. Steele, you mentioned about asthma control test. I know you like, you love it, not like it, you love that. And I think that it does help, but you didn't elaborate on it. What's the place of asthma control test when they come to you? What do you do to make sure that is the client controlled, uncontrolled? And what's the place of peak flow at home for clients, those who can afford?
Yeah, excellent question. So simply let me say that the asthma control test and peak flow are like your SFIG, as you would have for your blood pressure patients, and your glucometer, as you would have for your diabetes patients. So use these devices to check blood pressure control and then blood sugar control. So the asthma control test is also a way of checking how asthma is controlled, and just like the peak flow meter. So basically, the asthma control test is a questionnaire. It's freely available online, and it has 5 questions. So it asks patients questions like, in the past 4 weeks, but all the questions are about the past 4 weeks. So in the past 4 weeks, how much has the asthma kept you from doing the things that you would normally do? So the patients will tell you, asthma hasn't kept me from doing it. So each question is scored 1 out of, from 1 to 5. So if they haven't had any problems at all, it's 5. And if they tell you the asthma has been it's been so bad the past 4 weeks, I've not been able to do anything, I've had to abstain from work or school, that's about 1. Then you can have in between. Then how often have you had your asthma symptoms? I mean, the past 4 weeks. Oh, the past 4 weeks I've had it every day. So that may give you about 1. If they've not had it at all, they score 5. So it's like the higher, the better. Then it comes to how often have you used your reliever medication. So if they've not used it at all, they score about 5. And then if they've used it too frequently, they score about 1. And then you can have in between. Then you can ask them, you also ask them to subjectively tell you how the asthma has been overall the past 4 weeks. So based on what they tell you, you also score them. So you score them out of 25 because each question is up to 5. So as I said in my presentation, when they score 20 and above, that means that the asthma is well controlled. If they score less than 20, the asthma is poorly controlled. But if they score 15 and below, they are very poorly controlled. And the other thing about the asthma control test is that any change of 3 or more is a significant change. So if, for example, my patient came to the clinic last time and he scored 20, and this time he comes and he scored 16. Because the difference is more than 3, that means that it's a significant decline. So then I'll have to take an action. I have to find out why the patient has declined and take an action. On the other hand, if the patient improves by 3 or more, it tells me that it's a significant improvement. So the patient is doing things right. So as I said, assessing asthma control is in 2 domains. One is symptom control, and that's what you use the asthma control test. There are other tools, but there are numerical and qualitative assessment tools. The asthma control test is a numerical tool. Gina has a tool, which is also a questionnaire, which is a qualitative tool. It doesn't assign numbers. So based on patient's responses, you can say well controlled, partly controlled, or poorly controlled. Then the second domain is the future risk of the risk that a patient will have symptoms in the future. And you use a number of things. One of them is a peak flow. So if the peak flow is low, I mean, normally you compare it to the personal best. And what we expect is 80% of the personal best or more. And that is a good peak flow. But if they fall between 50 to 79, it's not so good. But below 50 is a problem. That means that they are declining. So what it tells you is that going from the clinic, if the peak flow is poor, that patient is likely to have an exacerbation. During one of my clinics, I was with one of my residents who is a specialist now. We had this patient who came in, and then the asthma control test was 20, which was good. But the peak flow was 37%. So my resident asked me, what does it mean? And I said, even though the symptom control is good, the peak flow is telling you that the patient is at risk of an exacerbation. And it was because it was so low, we actually decided that it was actually an exacerbation. So we put the patient on prednisolone. That was a Friday. The next Wednesday, the patient was, in spite of the prednisolone, she was back in the emergency room with an acute exacerbation. So the peak flow was telling you that even though the symptoms control was good, but the future risk of exacerbation was high. So sometimes you can give prednisolone. If it's not so bad, you can ask them to increase the number of doses per day of their ICS LABA. Thank you.
Okay, thank you very much, Dr. Stodazi. Dr. Smeni. So I have this one for you. In fact, they've gone through the 2024 guidelines very nicely. But when you are sitting in the consulting room and the client has come, I mean, they are talking about preferred and alternate. I want you to go through step by step. What is the preferred? What is the alternate? We are talking about step 1, step 2, step 3. Client has come. I've realized that a lot of, our colleagues, when clients come, They actually skip step 1, step 2, and most likely go and take this one daily. Some people actually are supposed to be at stage 3. They don't assess well, they tell them as needed. How do you assess to know that I'm starting step 1, step 2, step 3? And can you briefly take us through preferred and alternative in terms of the management?
Thank you very much. Right, so we are assuming that the diagnosis is correct and the person is asthmatic, right? So if your first time of meeting the person, you may not be able to be accurate in placing this patient if he's never been on treatment, because usually we're able to place you based on your response to a particular level of treatment. And so sometimes these levels are in retrospect, based on your response when we started inhaled corticosteroids at a certain level. Now, so if this person was on treatment before and he comes, your questionnaire would show, okay, what level of inhaled corticosteroid has he been on? Some people may not, in fact, I mean, those who are referred, most often they have not been on, significantly not been on inhaled corticosteroid. So in that case, it's like asthma has not been treated, and so you don't have any frame. You therefore have to, based on what is at hand now, to start from somewhere and review over a short notice to see whether this patient is likely going to, respond well to this, or is something that has to be escalated. So in trying to answer that question, you may not always be able to say that this person is at step 1 or 2 or 3 if that is your first time. You always need to have started some level of treatment and in retrospect judge to see their response. But if he's been on a particular treatment, even at the primary level or at the secondary level, you'll be able to judge. And assuming they were compliant, you'll be able to judge that this person has been on this level, is not doing well, or is doing well, and is likely going to be that. Now, step 1 means that this person usually has less than, out of the 7 days in a week, less than 2 of the days. And step 2, usually more than 2, but you don't have all the days. Step 3 means that he has frequent out of all the days. So it may be symptomatic almost all the days. And then step 4 is just based on the severity, how it interferes, sleep, how it interferes with daily activity, and how often they may have had to use their rescue, and so on. Right, so that is how you grade them. And preferred means, as of now, we know that there's no room for SABA. Up to 2015, you could have been doing well with your mild asthma on just SABA alone, all right, as and when needed. But we have evidence to suggest that there's no room for that now. So the preferred is the formoterol-based preparations. And on the Ghanaian market, we have budesonide formoterol preparation, right, which is in pediatric range, usually 80/4.5, the adults 164.5. And for instance, if you are starting a person at step 1 or 2, or you think he has mild, then it means that there's a room for as and when needed type of therapy, and then you follow them up to see how they respond. And if the person has almost daily symptoms, at least this person is starting from step 3. And at that level, some maintenance is needed. And we're saying that you can begin with 1 twice a day, and then option for as and when needed. Okay, and then you review them, the cycle that we showed. All right. When you get to about moderate dose of your budesonide, and this person is not doing well, it means that he's probably not step 3. He's going to step 4. And there you also optimize your, therapy. And if he's definitely not doing well, means that provided the diagnosis is correct, probably step 5, and that level has to be seen by a specialist.
Yeah.
And then you said alternative. Yeah, alternative, there are other ICS-LABA combination, but the cumbersomeness is just that you would definitely have to have, it's not as he said, is not been proven to be useful in acute exacerbations. So it means that when the person, despite using it, is having trouble, he must have to use a rescuer. So usually, as and when needed, short-acting beta agonists. So it means that you will be using at least 2 devices, right? And sometimes it confuses them because the person knows how to use this well, but he's not conversant with the usage of another device. So compliance sometimes may be an issue. But where the person, for one reason or the other, could not use one, definitely the other option is also there.
Okay, thank you very much. So what they're saying is that we don't use SABA alone. SABA, please, could you elaborate what is SABA? Because SABA, somebody would go and say, give you some definition of SABA that you may not like.
Right, so we're talking about a short-acting beta agonist. And on the Ghanaian market, we have salbutamol. The Americans, salbutamol, albuterol, So I think albuterol probably is on the Ghanaian market. I'm not sure. But salbutamol. Yeah. And to shock you to note that... So
what a lot of people say, Ventolin.
Okay,
Ventolin.
Yeah, okay.
You need to mention what they know.
All right, so that one I didn't want to commit myself because, it's...
Because I think it's what is really on the market. So,
yes.
And that's what
so commonly people call it Ventolin, but even though the other forms of salbutamol. And primary care practitioners are here. Please, some people are still on tablet salbutamol at this stage. I saw one Monday. Okay, so please, somebody says it's not good enough. All right, so.
Thank you very much. In fact, somebody has asked that particular question, so we'll elaborate a little bit on that. But Dr. Pabi, please, can you help me? The guidelines for adults, is it the same in the management for children? Because there are slight differences, and I think that people should know about it. Because it's giving us a clear one as to what to do in the adult. But in children, how do we go about this?
Yeah, so I think just as you say, basically the principles are the same, but just that there are some slight differences. Like I've said, usually step 1, step 2, they recommend using the SABA, and then as and when they get the exacerbation, you add the inhaled corticosteroids. But like I said in my presentation, for me, you see, for adults, most likely you've been able to establish a diagnosis right from the word go. For children, it's not like that. And the more you wait for the child to get the episodes, before now you begin to go full throttle. I don't think, because I always say that when you have an exacerbation, take it that you are being strangled. Somebody has tied a rope around your neck and is strangling you. What you want is to get relief, isn't it? And if possible, kick the person out of your life so he never gets opportunity to do that to you again. So for me, I recommend that once I'm certain that you have on clinical grounds that you have asthma, I want to start you on the inhaled corticosteroids, the preventer. Of course, like my colleague said, you can be weaned off. So we put you on it for about 3 months, 4 months. If you are not getting any exacerbations or whatever, we maybe do alternate daily for another 3-4 months. If you are not getting anything, that's okay. There probably may not be asthma, so wait, and then let's see. If you get again, you will start, and then, or if you are on it, but you are still getting it, we can do. So it's basically the same, except that because of the difficulty in confirming that this is asthma or not, for me, like I said, it's better I become a prophet of doom. But I tell you that your child has asthma and then he never gets doing the right things for the child never to get an episode again, which means that I was wrong. I'll prefer that than saying, it's a hyperactive airway, or using something, this one is nothing, and then the child keeps coming, getting it. So
let me push you on this one. So a child below 6, after 6, when can you use the inhaled corticosteroids and the formoterol both as a reliever and a controller?
Yes.
How do you go? At what age do you prefer to use that? And at what age would you prefer to use the inhaled corticosteroids and probably the SABA as a
So
reliever?
the challenge is the device and how they come and the ability of the child to be able to use the devices. And so that is why usually below 6, then they will be on the SABA and then with a different inhaled corticosteroids. But then after 8, usually I say after 8, they should be able to use the inhaled corticosteroids, the ICS formoterol preparation because of how they come in. So usually, yes, depending on how well the child is able to use the devices that are available, then yes, from 6, 7, 8 going, you put them on the ICS formoterol. But below that, usually the ICS and maybe another SABA and another ICS.
Yeah, I think so. Does want to add something?
So let me add a bit to that.
Hello?
So I'll add a bit to that. So in the guidelines, there are 3 age categories that recommendations are made for. So we have the children 0 to 5 years in one category, and then 6 to 11 years in another category, and then 12 years and above, and adults in the same category. So what we've talked about so far mostly apply to children, children 12 years and above and adults. That's why we have the alternative tracks and then the preferred track. And it's similar for 6 to 11 years. So children 6 to 11 years can also use formoterol, budesonide as needed or as needed plus maintenance. But when we come to children less than 6, they are limited to only plain corticosteroids. They don't use the inhaled corticosteroid long-acting beta agonist combinations. So the options they have are salbutamol and plain corticosteroids like beclomethasone or fluticasone. I mean, popularly we have flexotide. So it is inappropriate and not based on guidelines to prescribe Symbicort 84.5 to a child who is less than 6. Less than 6, because it is not recommended. And they have 4 steps. So, you can give a child salbutamol, beclomethasone inhaler with spacer. And they use it as we said. So if the child doesn't have daily symptoms, you tell the mother, okay, these are 2 inhalers. When your child has symptoms, give salbutamol inhaler, and then at the same time, give the beclomethasone or fluticasone. And mind you, the doses when they are using the salbutamol are different. That's when they are using the salbutamol with the spacer. When they are using the salbutamol with the spacer, for children that age, they need about 4 to 6 puffs in the spacer, but they deliver it one after the other. So they puff one into the spacer, they take 5 to 10 breaths, puff another one, 5 to 10 breaths, and when they are done, they go on to use the beclomethasone or flexotide inhaler. Those ones they do just 1 to 2 puffs.
Okay, I think that we have some few minutes to go, just about 5 minutes, but can you take this one, that what actually informs inhaler choices? You've talked about techniques, you've talked about all that. There are different types on the market. Somebody is at your clinic, what informs the choice in the inhaler that you're going to be prescribed?
So let me say that it's mainly what is available on the market. So now we've talked about the preferred option and then the alternative option. So the question is, what formoterol ICS option do we have on the market? So that is a major determinant. Now it looks like we have only one choice. So very important. And also, you look at your patient. There's what we call patient's health literacy. So what can the patient handle? Some patients will struggle to use the dry powder inhalers because those ones, they need a bit of effort. So you may decide to opt for a PMDI. I had the mother of one of our professors come to see me one time, and she was so old. And based on her symptoms, I knew she needed to be on the table healer. But I realized that, even taking her through the technique, she wasn't going to be able to use it. So I had to put her on the pressurized metered dose inhaler, salbutamol, and then beclomid. Those are some of the practical things that will determine what is on the market, who is the patient in front of you, and then also what has the patient experienced before. Has the patient been comfortable with this or that medication? Has the patient had issues with this medication? And then I believe there may be a few. Have they had side effects? So those are some of the practical considerations.
Okay, Dr. Asmani, this one goes to you. You started with the oral medications, bronchodilators, oral medications for managing asthma. I mean, you see a number of clients, as you said, they are on oral medications. Sometimes oral salbutamol, they have other theophylline and other things that they are on. And secondly, people actually stay at home, actually nebulize. They bought a nebulizer at home, sitting by their bed and nebulizing when they have and come. What's your take on it, quickly?
Well, the last one first. Now, nebulization is not recommended as, the usual way of managing day-to-day chronic asthma. It's meant for certain people who cannot use the available devices that we have. And then sometimes children, of course, who cannot, make head or tail even with a spacer. So that is not recommended, by guidelines. That you ask for you because you can afford it. You just say that is my way of managing my asthma, just by the nebulization, especially when you have to use short-acting beta agonists. All right. So. Yes, it has a place. For example, you are home and you are realizing that based on the escalation of symptoms, you are in acute attack and you have the facility. Yes, you can nebulize and then, of course, consult your care or let's say your healthcare giver. So that's, but it shouldn't be like the routine where everybody feels it's like a form of better way of managing it. Okay. And then the oral medications are not backed by guidelines. So Ghana, we have some oral medications like asthma drain, asthmanol, and salbutamol preparation, tablet, and adults are on it, So please, it's not backed by any guideline. The side effects are too much. Sometimes it gives them unnecessary tachycardia, the tremulousness, they can't sleep, and so on. And so please let us get one up. A patient on Monday who has been on tablet salbutamol for the past 3 years, and that's all, no ICS. So please they will get relief, but the side effects is uncalled for. So that should not be encouraged.
Okay, thank you very much. Dr. Pabi, I think this will be your last part.
And let me mention oral. Oral prednisolone is not meant for long-term, asthma management at the primary level. Okay, because even though they will get some benefit, don't just put them and leave them there. And usually, even acute management, there's no evidence that beyond 5 days you get any evidence. Whether you decide to tail it down or not, in terms of exacerbation and so on, beyond 5 days, you don't get any benefit.
There's a question on this one. Somebody's asking about oral prednisolone and IV hydrocortisone, because in the district, sometimes they know that in acute exacerbation, the only thing you can give is IV hydrocortisone.
Oh, no.
I mean, what is the evidence?
The evidence suggests that one is not superior. Oral or parenteral is not superior. Our able-bodied, pediatrician made us to know that contrary to what we believe when we're medical school, there's a receptor on the cell membrane, and that is responsible for the immediate responses that we get from steroids. So whether parenteral or oral, these get almost the same effect, almost at the same time. One is not superior. What would determine when I give parenteral is when the person is so bad he cannot take oral, or he's vomiting, or he has some condition that malabsorption. Otherwise, one is not superior, and the evidence is clear.
Dr. Pabia.
So just to stress this point, asthma attack does not mean that you should always give hydrocortisone injection. It is only when the patient, for one reason or the other, cannot at that time take the prednisolone. Other than that, is the prednisolone. So hydrocortisone comes in only when the patient, for one reason or the other, cannot take the prednisolone. So let's not be in the habit of giving every patient with asthma attack hydrocortisone injection. Is totally unnecessary. Thank you.
Dr. Pabi, so somebody is asking, you've talked about steroids and inhaled corticosteroids as well. What's the dose? Some people are asking, when you're nebulizing for steroids nebulization, what's the dose that they are supposed to use? 2, in children, they are talking about side effects. A lot of people actually think that if you are going to give it, especially in children, because of the side effects, they don't even start. What's the evidence behind using the inhaled, especially in sense of the side effect profile, and what's your recommendation?
All right, thank you. So usually in children, when I'm asked about doses, I hesitate in mentioning doses because everything is per kg. We do per kg, a lot of per kgs. When I came in, someone was calling per kg. So, but for the inhaled corticosteroids that are available, usually 250 microgram, maximum maybe 500 microgram per nebulization is acceptable. Not more than 2 grams in a day is what is recommended for children. Now, with the side effects, like I mentioned earlier on, yes, we are so scared of steroid and their side effects, but the side effect is very, very minimal. In fact, evidence shows that the long-term side effects of steroid, if you put a patient on steroid for a long time, maybe it may reduce their height by maybe 0.5 centimeters or so. But then the question is, if you don't put them on it and they keep having the exacerbation, what is the long-term effect of having chronic, uncontrolled asthma for, a long time? The effect may even be more than, the growth may be affected more than the 0.5 centimeters in height that they may suffer from. So, like I've said, once we are using the inhaled corticosteroids, the dose is so minimal that we should not be so scared about the side effects, because what is the point in preserving your height if you are not alive?
Thank you very much. What's the point in preserving your height if you cannot live to know even how high you can go? Your last words, last word from you, but to add to it, I think Chair actually made a point on the new targeted biologic therapies and immunotherapy. Add to it and your last word. Then I come to your last words and your last words.
Well,
the place of this new targeted biologic. Because some people think that I have the money. Can it cure me?
No.
What's the place of this? Please?
Right, biologics are add-on therapies. So, and it's meant for very severe asthma, especially when it's phenotyped, proven, because it's not every severe asthma that will benefit from biologics. We have ways of determining who would benefit, and those who tend to have the so-called T2 high type of asthma will tend to benefit. And it is not a primary or let's say first-line drug. Usually you have to have optimized your standard of care, and those who are not doing well, when you are phenotype them, then they can go on. So yes, you may have your money, but that alone will not replace the standard of care based on the available evidence. And then if we don't take anything from this...
before you give me your last words, I think I left my in-house audience. I think all your questions have been answered, right? Great. I made sure that I captured all your questions that you have put online. Your last words, please.
Right, so there's no room for using short-acting beta agonists alone in the management of asthma, regardless of the level of severity. Inhaled corticosteroid and formoterol-based preparations are the way. Thank you.
Dr. Pabi.
Dr. Swanu just told my last words.
Your children are listening to you.
He's told my last words. So please, asthma management, make sure that there is inhaled corticosteroids in in addition to the short-acting beta-2 agonist. And then guidelines are guidelines. Sometimes we stick so much to guidelines, meanwhile the patient is right before you. There is no better guideline than the patient that is before you. So yes, like we said, the asthmas they are very, very different. They are very, very different. So you may be following the guidelines, but the patient is not getting better. Please look at your patient very well, and then manage your patient. Make sure that you are in total control of the patient. Thank you.
Dr. Sundazi, as part of your last, somebody is asking that they are in the health centers, but some of the things that they are mentioning, I mean, are they insured? Can they use it at that level? How is the Thoracic Society of Ghana, and all that they are doing, making sure that all these things are available up to the primary care level? I'm talking about the last primary care level, the health centers and other places. I don't know what work you are doing. Probably if there's something and some advocacy that is going on, because we are saying that it is necessary. Do they have it?
See, let's forget about this business of we are in the village. Look, the people in the village are not different from the people in the city. The pathology of asthma, as we've talked about, is not different from pathology of asthma. I mean, the pathology of asthma in the village is not different from pathology of asthma in the city. So it is the responsibility of doctors everywhere to ensure that the facilities are well, placed to take care of asthma patients. The medications are available. The only limitation is that doctors are not prescribing them. And that is the main problem. So I think that we should all take up that responsibility to ensure that, irrespective of where we practice, these medicines are available. As Dr. Nketia, or as has been said, they are even on insurance. So why don't we just prescribe them?
Dr. Sudazi, my people in the health centers are shaking their heads. Is it insured at that level? Being available and being insured for the client is totally different. Okay, I think that we need to look at this thing. If we need to advocate to make sure it is a guideline, they need it. The physician assistants at the health centers, are they allowed to use it? Is it insured for them to use it?
Yes.
And I think that
it is.
It is.
No, some time ago that was a problem, but we worked on it. So when I was some years ago, when I was running my asthma clinic at the polyclinic, I could not prescribe Symbicort because it wasn't. It was only allowed to be used at a tertiary facility, but it was changed. And as far as I'm concerned, unless I'm wrong, it is, you can prescribe it at a primary care level.
Primary care level, there are 3 levels.
I'm not sure about that.
Yes. But, okay, probably, okay, somebody will want to, whether, probably it works at that, to let us know whether indeed it is there, because I think we need to. If not, we will, probably, our chair is here. We can charge our chair and the president of the Thoracic Society to make sure that they advocate for that.
Yes, so my name is Baba Isa, AstraZeneca, BA and the North. Yeah, so I'm at the primary care level. So if the level is B2 and above, that is health center with a doctor, health insurance will cover.
Health center with
a doctor. That's so B2.
Without a doctor?
Yes. So without a doctor, the health insurance will not cover.
Yeah, that's what I'm talking about.
Yes, so as Dr. Dazi has said, if you are a PA at a health center without a doctor, and your patient has asthma, and the guidelines is saying, give budesonide formoterol, and your patient can afford, the choice is yours.
Okay, thank you very much. I want to give my last words, okay? Standing in the place of the president of the Pharmacists of Ghana, I'm saying that most of the health centers are manned by physician assistants. Trust me, that is the community level of care. And if this is not insured at this level, I don't think that we are doing well as a country. And I think that we need to come together to make sure that we advocate so that these things are insured. Because most of them at that level, when they get them, may not be able to afford if it's not insured. And I think that is our duty. I mean, as a country, and as colleagues and as physicians to make sure that we advocate so that it goes down to that level, because that's why they are asking it. All that we are talking about, they are the health centers, they are listening to you, but they can't because there's no doctor. How many health centers in Ghana have, doctors there? Most of them don't. So let's advocate, let's push. AstraZeneca, I'm putting it on you. Thoracic Society of Ghana, I'm putting it on you. Society of Pharmacists of Ghana, yes, we also are pushing as well. We need to get it there. On this note, I want to say thank you to all of you for, being a good audience. We've gone beyond time, but I know that it's been good. A lot of learning points here. And the management of asthma in Ghana, I'm sure, is going to change. I'm sure we have over 1,000 people actually online with us. Most of them at the district levels, at the primary care level listening, and I hope that they've gotten enough and it's going to help with care. Thank you very much and stay blessed.
Right, thank you very much, Dr. George Nketia, for leading this panel discussion, and to all our panelists. Please, can we put our hands together as we appreciate them? I think we started this meeting with a chair. It's not out of place if we have her giving her final remarks, her closing remarks, after which we would have the country director for Sub-Saharan Africa and AstraZeneca in the person of Mr. Bukri, giving us her final remarks. So put your hands together as we welcome Doctor.
Thank you so much, audience. Thank you for the time that you've spent. I know it's been a long day, so we need to get out of here as quickly as possible. We thank our speakers for the wonderful presentation they have given us. I stand again in the shoes of Ghana Thoracic Society. I must tell you that we do have severe limitations in our cascade of health system. Now we are here in Accra, so we talk in line with the guidelines. I really appreciate what happens down there, and sometimes it's so difficult for the clinicians down there in managing cases. I used to say, no tablet, no tablet, no tablet, until I got confronted in some village. And then I realized that I should change my terminology. Now, in the greater Accra district, please, no tablet. But in some situations, that's probably the only life-saving drug they have. But we will get there. It only tells us that as Ghana Thoracic Society, we have a lot of work to do. In fact, spaces, we should promote it because it will help a lot. Now, leave here with just this summary. Okay, in managing chronic asthma, we are saying that ICS LABA is the option. It is the option. Now, that option, you have two further options. One is the formoterol-based preparation and the non-formoterol-based preparation. If you have the formoterol-based, forget about step. If you have the formoterol-based, then you know that I can use this both as what? Maintenance and reliever. If you are not using the formoterol-based, then you know that it is a maintenance. Then you need two further inhalers, a short-acting and then a pure ICS, to be used as what? Relievers. So it means that whenever you use the short-acting, you must also use the inhaled corticosteroid. Now, the challenge is that people with dexterity issues and, not able to use these devices, a spacer would have been a great thing for them. So they have the option of using the formoterol, non-formoterol, but then they can have these extras for their reliever. This is what I want you to leave here with. In the children, Dr. Pabi has told us, it's the recommended age that needs the ICS LABA. Never do we have only LABA as for use in any asthma patient. In fact, it is not available on our market. We also want to encourage that in as much as asthma diagnosis is clinical, and we stress on that. Now, you must not forget the aspect of response to treatment. I don't have spirometry, I don't have peak expiratory flow rate, I can still diagnose asthma, but I must ensure that I have response to the treatment. If you don't have response to treatment, then you know that you could have erred. So you need to move your patient on. I like the way we're talking about the spirometry. It's not available in most places. But whenever you make your clinical diagnosis, ensure that you have response to treatment. Is that okay? And then just remember that we can always do spirometry. Even if you've started treatment, don't worry. We only need you to be off the ICS LABA for at least 12 hours. Once you've been off for 12 hours, we can always do spirometry at any point in time for your asthma management. For acute, please don't forget that never nebulize without driving it with oxygen. I've seen people put the mask on patients' faces. They are already in bronchospasm. They are nebulizing them. They can't breathe. Please, once you put it there, you've reduced their access to atmospheric oxygen. They are already struggling. So never nebulize acute asthma without driving it with oxygen. Thank you very much. I think I'll call on the country manager, Sub-Saharan Africa, to give us a closing. Director.
Thank you, Dr. Mensah, so much. I walked into your country just 4 hours before. Thanks to the Kenyan Airlines and the driver who brought me exact at a time when I had Dr. Samuel Asomani, who was onto his first slide. So I must thank the whole infrastructure here. By the way, I am in Sub-Saharan Africa only 3 weeks before when I landed, almost 3 weeks before, and I'm, as you would have guessed, I'm an Indian, but I'm going to be based out of Nairobi, managing the Sub-Saharan Africa operations. And it had been I know we are late in the evening, but I'll take probably 2-3 minutes more of it. I think it had been an intellectual feast, I must say that, as soon as I entered. You would have seen I never got up off this table except to have a cup of tea, although it was a 5-6 hours long flight that I landed. But I think I could not, and I complimented each and every speaker, Chair Ma'am, you individually, but I think it was such a superb. I think, give me a minute to just also thank the Ghana Thoracic Society and Society of Family Physicians of Ghana. Listening to all the deliberations, I believe asthmatic patients of Ghana are in safe hands. I mean, that's my impression, because asthma, as every speaker talked about, is a very debilitating disease. It's not something which can be detected easily because of the symptoms. Treatment and making more complex is the whole technique of inhalers. I think so I think if you look at from a journey of what you, Dr. Asomani, talked about, I think budesonide, what I heard and what is the take-home message, and thanks to you, ma'am, for reminding. If you have got a formoterol with an ICS combination, you don't have to look anywhere else. Can we make this country SABA free? I mean, it's a loud talk, but I don't know, but maybe a stage will come when people will start talking about, not as someone said that SABA is bad, but I think over a period of time, our experience is that the formoterol based combinations which have got our ICS are the one across the steps, I think, which is also a take home message. So thank you, Dr. Asomani, very much. And then came, of course, Dr. Pabi in his own style. I mean, the load that he shared about in his hospital I was stunned to see so many patients and so many acute patients, and thank you so much for enlightening the audience of how do we deal with it. Of course, Dr. Stelle, I mean, we were so impressed by your talks also, not only in terms of the guidelines that you talked about, Gina, but also, I mean, what differentiates some of the other diseases from asthma is probably the device. For rest of the thing, it's a pure pill or an injection. Asthma is one such typical disorder. So thank you so much, I think. And I can't even thank you, Dr. Nikita, a lot, because you had been you stood there. You were the only person who stood for the maximum time, and when all your speakers were sitting. So thank you so much, I think, for all those efforts and bringing some of the things live. I mean, to me, icing on the cake is always when you ask some practical questions. From theory to practical, I mean, you made the life so well. I think Prince, I don't know where is he, but I think I want to thank Prince from AstraZeneca with the way he demonstrated and made everyone play with the inhaler. I mean, it's important for every one of us to make sure that we do that. I think last but not the least, thank you, lovely audience. It's almost 8 o'clock. You are still sitting. Thank you, audience. Last I came to know, there were around 400 audience who were glued online. I mean, technology is making us. So thank you in case if you're still there. Thank you so much for coming and thank you so much, Mabel, you and your entire team of AstraZeneca. Lastly, a commitment from AstraZeneca has always been to partner with healthcare organizations, with physicians to make sure not only we give you the most innovative drugs, but also how do we make sure that we give you platforms, how do we make sure we give more diagnostic tool, and that commitment as I have entered into the role will continue for your country. Thank you so much.
All right, thanks so much, Mr. Ahmed Bakri. So it's time for us to go for dinner shortly. So one thing you want to know, you'd want to do is to watch out and look out for your triggers. That's just by the way. So let's make sure that we have our names on the attendance sheet for our CPD accreditation in case you don't have your name on the list. So it's time for dinner, and each one of us should have a coupon to have access to dinner. So if you have that, that's fine. If you don't, then you can see my colleague, Dorothy, for a coupon before you go to the restaurant for your dinner. Thank you so much for coming, and to our online viewers, thank you so much. We really appreciate your time.